30.7, and you see that the lowest rate seems to be this Middle East and China, where it is 5.2%. This is for cervical cancer. So it is shown clear that I was saying in the morning that people used to say that this is a disease of underdeveloped countries, people who with poor hygiene, with poor socioeconomically population. So maybe this is the one the reason they say so. So where do we have it most in Eastern Africa, East and Southern Africa. So and it is less in Middle East and China, and probably they say in the Middle East it is lower because of their custom of circumcision, because circumcision in men protect their women, protects them from getting the virus HPV. So the risk factors, so these data are from this book, the WHO classification of tumors for pathology and the genetics of the tumors of the breast and the system. So they say early age of intercourse, sex intercourse, multiple sex partners, and the explanation here is that having multiple sex partners exposes a woman to have to acquire different serotypes of HPV, including the high risk ones, and also the lady can be maybe she doesn't have many sex partners, but when her husband has many sex partners, also they will infect him and he will infect her, his wife. So umugore ashobora kuba ari serious ariko umugabo natari serious n'ubundi risk ziba zihari. Poor hygiene and circumcised male, because with circumcision, at least the hygiene of the man is increased, and therefore the hygiene of the woman also is improved. And poor hygiene exposes to acquire these viruses and keep them. Immunodeficiency, and probably this is why in Southern and Eastern Africa we have many cases of cervical cancer, is because also they have a high incidence or prevalence of HIV/AIDS. High parity, so having many children, poor nutritional status, infections other than HPV, smoking, and oral contraceptives. There's estrogens and so on. So these are those listed by the World Health Organization in this book. These are books we use in pathology. We use them to categorize the diseases. So I think it is understandable, everything here. So for the stomach, so here we are having a picture of the stomach. We have the rugae here, but in the center we have a tumor serrated in a necrosis in the center. So what are the risk factors? As found in so the books I'm showing, they are the books from which I took this information. So the first one was for breast cervix, it was from a WHO book. Now in stomach, I took this from the Robin's Basic Pathology. There is chronic gastritis with intestinal metaplasia. You remember metaplasia, what it means? And the metaplasia in the stomach, when the stomach cells are not able to continue to cope with, let's say, high H. pylori infection, inflammation, and high acid production, then they behave like intestinal cells. So there are goblet cells with a lot of mucin which come there. So normally when we see this, when we see this on histology, it means it is almost a precancer lesion. So when you say there is intestinal metaplasia, it is like a dysplasia. The risk of having a cancer is quite high. That's why something usually is done when we diagnose this. So most always in this case, they have a Helicobacter pylori infection. The nitrites derived from nitrates bitwabonye mu gitondo cyane cyane bikoreshwa nka preservatives in prepared meats. Diet containing foods that may generate nitrates such as smoked foods, pickled vegetables, excessive salt intake, especially abantu bafata umunyu bakawongera mu biryo bitetse byamaze gutekwa biri ku meza. So it is a high risk. So I don't invent anything here. As I said, these are from this book. Decrease the intake of fresh vegetables and fruits. So taking fruits and vegetables will increase the chance of having antioxidants. And these antioxidants, they help the body to cope with some mutations. Kubera ko oxidants ibibazo zitera bya mbere byinjira muri DNA bigakora cross linking between DNA molecules. Then that cross linking becomes like a mutation. So when then you eat antioxidant, they prevent this oxidation of and cross linking of DNA strands. Partial gastrectomy. So people who are undergoing partial gastrectomy, maybe because of ulcer, they have increased the risk of developing the cancer. Pernicious anemia. You know, you have had a hematology, so this is also a risk factor to gastric cancer. How about intestinal cancer? So here, first of all, we have a diagram showing the pathogenesis of intestinal cancer. Let's say it is a colon. This is a diagram, not a true picture, of course. So we have a normal colon with mucosa, submucosa, muscalis propria, and of course there is a serosa below. So a mucosa at risk, of course, there are no changes histologically, but at molecular level, you can have methylation abnormalities and activation of normal alleles. And usually, a normal colon may have one mutation, germline or inherited or somatic acquired mutations of cancer suppressor gene. Twabonye kare ko yo hafashwe kamwe allele imwe ntacyo bitanga kubera ko this is expressed in a recessive autosomal way. So having like a mutation in APC, this is adenosis polyposis cori gene, chromosome 5 long arm region 2-1. So having this mutation, which is in a tumor suppressor gene, it can not by itself cause a cancer. But when the second allele is then inactivated, now we'll have a second hit. So double hit theory. So therefore here, this person will be likely develop a cancer. But no, a cancer doesn't come automatically. First, it starts with adenoma. Adenoma, it is a benign tumor from these glandular cells of the colon. And you can see here, it is just a tumor which doesn't infiltrate here in lamina propria or submucosa or the muscle. So adenoma is benign, but it is always good to search for the possible causes of adenoma, because it can be a predisposing factor to have a cancer. But when you do sequencing or molecular study on the adenoma, you can find these changes. First of all, usually there is a proto-oncogene mutation. You remember proto-oncogenes are these which promote cell growth, and one mutation is enough. One mutation in one area is enough. So such as KRAS at chromosome 12 short arm. And then here, usually patients they have homozygous loss of additional cancer suppressor genes. So we had one suppressor gene which has a problem. Now there is another second tumor suppressor gene which has a problem. So such as P53, which is located at chromosome number 17, loss of heterozygosity at chromosome 18, and so on. And usually there are other additional mutations in carcinomas, apart from this one they seen in adenoma. So in general, most of tumors of the colon, they start as a normal tissue with changes we cannot see on histology, but molecularly you can see. And then adenoma. And then from this adenoma, if nothing is done, there will be a carcinoma. You see that it has destroyed the whole wall so perforation is even possible. So the risk factors of intestinal cancers, there is a familial predisposition. Yango murabyumva nera germline mutation cyangwa se usually germline mutation umuntu yarazwe n'umubyeyi cyangwa ababyeyi be. So here we have many syndromes. Tuzabigeraho muri systemic pathology. Hari abagira familial adenosis polysyndrome, hari abagira mismatch repair problems, and we are doing a study on this to see how this is in our population. Kako dufite babonye ko dufite abarwayi benshi bari bato cyane bivuga ko bashobora kuba ari familial syndrome. So dushaka kubikoraho ubu. There is the diet and the lifestyle. So bya bindi bijyana byose gutuma umuntu agira fat nyinshi, poor vegetables or fruits intake, chronic inflammation for any reason, and irradiation. So umuntu ashobora kuba irradiation bamuvura nka cancer ya prostate cyangwa ya overe na intestines zigafata ya za rays then bikazatera cancer. As you see, this information is from the WHO book of the tumors of the digestive system. So what about breast cancer? So breast cancer, breast tissue is rich in fat. Where it is yellow here, it is fat. There are some white tissues, small ones. These are fibrous tissue within the breast. Occasionally, the glands of the breast na ducts in zinura. But here on the right side, we have a carcinoma, which is a solid whitish invariance of hemorrhage. So what are the risk factors? As I said in the morning, the WHO and the other researchers, they have tried to categorize them, well-established influences, and as another really debatable, but bakijyaho impaka kubera impamvu navuze hejuru. Ko bashobora no kuba impamvu. So the first, there are geographic factors. Nkuko mwabonye ku ikarita nako kuri data narekanye kare kuri epidemiology. Breast cancer is more seen in developed countries than in developing countries. Age, birumvikana uko umuntu akura guhera ku myaka 30 niho bazigira. But there are exceptions because there is a case we had in 2014, in the 2015 or 2015. At the Sashika, she was 12 years. She was from Kigali, so she came. And we thought it is maybe inflammation because there was a severe inflammation. But when we look at the carefully on histology, we found there are cells which are very bad. Said that maybe there is a mistake, maybe it is a reaction, it is not true cancer. Then we requested another biopsy, it was confirmed. Then we confirmed it was a cancer, and unfortunately she didn't survive. She died in a few months afterwards. So there are exceptions, but most of the time they are more than 30 years of age. So family history, first degree relative of breast cancer, first degree means a parent or a daughter or a sister. So having a breast cancer, usually you must be very careful. Menstrual history. So this I said, if the menarche comes before 12 years or the menopause is after 55 years. So this, the implication is that this person has been exposed to hormones for a long time, especially estrogen. So pregnancy, the first live birth after 35 years. So having the first child after 35 years, or being in illiterate, meaning no children, and also here having a live birth. Normally here it implies to breastfeed. That is the meaning. So it is not enough to have pregnancy. Of course, during pregnancy you are protected because the progesterone goes high, but you must also breastfeed. That's why a live birth means you have a live child that you breastfeed. But if you don't breastfeed, the child is alive, maybe the mom is not alive. I don't know how to express. So benign breast disease. So I said that the girls around 20 years, they used to have a fibroadenoma, which is benign, but you must be very careful because this is considered as a risk factor to have a cancer. picture, the cancer of the breast. So here they say this were established the influences or the influences which are debated. Exogenous estrogens. So I know is an oral contraceptive, of course. Obesity, high fat diet, alcohol consumption, cigarette smoking, and so on. So how about prostate cancer? So prostate cancer, it is said that more than 50% of men of more than 80 years of age, they develop prostate cancer. I think I explained this in the morning that, but when they are aged and they have a cancer, which is historically not very aggressive, usually you say there is no need to do surgery. You can treat using hormone replacement. Because the risk factor hanga ni testosterone muri rusange because they saw that in inax muri Bibiliya ita inax cyangwa se aba inkone, so they never develop prostate cancer because they have no testes, therefore there is no testosterone production. Ibihari nkeya ikorwa na adrenal glands. So where they have a means, because the hormonal therapy is very expensive, babaha imiti which mimic testosterone but which is not testosterone. So icyo gihe bituma igenda ikaburizamo gukorwa kw'indi testosterone, so bikaba protective. Na cancer yawe hari igashonga, so but this is not available. Those drugs are very expensive. So the option we have here in our settings is to remove the testes, and when possible, so remove the prostate itself. But in some instances, the cancer is too much advanced, you can't do it. So the age is a risk factor. Becoming older, also the risk of having this cancer increases. The race. So here there is a problem because they saw that the incidence per 100,000 men, black men in the US, about them, among them, 225 of them develop cancer, prostate cancer. But for the whites who live in the US, only 91. And when you look at the Indians, it is only 3. So here they saw that even when they live in the same country, the risk of developing prostate cancer differs by race. But now, when it comes to geography, it was seen that although we see that they are Black Americans, they have a high risk to develop prostate cancer, it is opposite for the Blacks who live in Africa. So there are studies made in West Africa because it is assumed that most of the Black Americans, they come from West Africa. But in West Africa, the prostate cancer incidence is low. Africa, this may be due to the poor data recording. It's possible, but this is an observation. So there is a testosterone, as I say, in the lifestyle and the diet. Usually here they say yes, to be sedentary, to be obese, to eat fatty food, there may be a risk factor. And so we did a study on this, and it was published in 2014 in East Africa. So, and this information is also coming from this WHO or classification of tumors of the urinary system and the male genital organs. So that's what we can say. It is just a glimpse to just for you to understand that not all cancers will be found in the same population. So there are some cancers which are more prevalent in the Africans, others more in the Europeans or Caucasians, and so on. And the gastric cancer is more prevalent in the Asians, prostate cancer in the Africans, breast cancer in the developed countries, cervical cancer in the developing countries, and so on. So the biology of the cancer. So muzajya mubona nitujya muri systemic pathology, we will talk of staging and grading. What is staging? Staging, it refers to the extent of the tumor. Is it small? Is it limited to one area maybe of gastric tissue or intestinal tissue? So here we have an example of colon. This is a colon wall. You do a biopsy here, and you find that there is a high-grade dysplasia. Dysplasia is not a cancer, it is a precancer. That's why the stage is 0. This is not cancer. But now here you find a cancer which is limited to the mucosa and the submucosa. So this is the stage 1. And if the tumor goes to the muscle and it just breaches the pore thickness of the muscularis propria, it will be stage 2. If the tumor goes even beyond, it infiltrates the fat and or it affects the lymph nodes, because here we see lymph nodes are white, so they don't have the tumors. But here the lymph nodes are reddish, so it is just to show that they are infiltrated. The stage becomes 3. Even if for the coronal wall itself, the extent of this tumor in stage 3 is almost the same as stage 2. But here lymph nodes are affected. If the tumor has gone metastatic, you see this is a liver with nodules, so this is stage 4. So that's why you will have people saying, okay, this patient is stage 4. The other one is, you say stage 4, it is the incurable disease. So you can just take it off the patient, but palliative care, not curative. Curative, you have intent to make that disease to be cured. Palliation is when it is not possible to cure the disease, but just you help the patient to have a better life. So I think this I have. Yes?
Victor, question on the previous slide.
Yes?
I didn't get at what stage the cervical intervention, where there is a cervical intervention, surgical.
Okay,
At which stage? Yeah.
Okay, I got you. So I think I should have mentioned this. For each organ, there is a protocol. So you cannot say if it is stage 3 in breast, you can do surgery. Doesn't mean stage 3 in stomach, it is surgery. So each organ has its own protocol. And that's why we will have a systemic pathology. So for example, for breast, when it is a stage. So I must also mention that there is a stage we give as a pathologist, and the clinician combines with clinical findings and the radiological findings, and at the end they give a final staging. So our staging, we add a word P to mean pathology, and the others they add C to mean clinical staging. So sometimes they give a clinical staging which is lower than what we see on histology. So they must combine always and consider the highest stage of the disease. Because sometimes also they can take a small biopsy or only a colon, because they don't take biopsy at the same time in the liver. So for us, we say it affected the whole thickness of the colon and the lymph nodes. We have a stage of B. But because we don't have information about the metastasis, because the clinician will have information about the radiology CT scan, then they will combine. If there's a metastasis, they decide this is stage 4. But in general, what I can say, not in terms of staging, when a cancer is metastatic, surgery is not done. So it can be metastatic and be stage 2 or 3 or 4. It depends on the organs. So each organ has its own staging system.
Yes, thank you.
So this I had explained in the morning, metastasis. So ikingomba kumenya clinician, and this also I used to tell to other healthcare professional students when I teach. Hari ikintu nibura cyoroshye, if you suspect a person is having a cancer, ukabona umwijima wa echography cyangwa radio, ukabona ko harimo nodire nyinshi nk'uko muzibona aha ngaha. Usually this is a metastatic disease. Ni cancer yavuye ahandi yaje muri liver cyangwa niba nibiha cyangwa ubwonko. So but when it is only, for example, one nodule, you write is a primary tumor there. So that iyi ni clue mugomba kumenya. rero njya muri stage bakakubaza uyu muntu urabona afite nodule nyinshi, so do you think this is primary from this organ or metastatic? You should promptly reply this is a metastatic because we have many nodules. So ntabwo rero ushobora kubona umwijima umeze gutya ngo uvuge ngo this is a hepatocellular carcinoma. No, in numerous nodules, these are metastatic, and here this was coming from the colon here, and they have a liver metastasis. So that's staging. Another feature we look for is grading. So grading, bijyana byo kuvuga, are these cells similar to a normal counterpart tissue or a normal, a mature counterpart? Nabivuzeho kare niba cells zisa n'iza skin, ariko ikaba ari invasive cancer, carcinoma, then you would say it is a grade 1 or well differentiated. So uko differentiation igenda iba nkeya ukayana aho ziba ko ari differentiated or undifferentiated, niko iba more aggressive. So lower grade, less aggressive. Higher grade, very aggressive tumors. So that's what you can retain. Higher grade, more aggressive. Navuze kare kuri buccal lymphoma, so maybe this you will ntabwo mbizi no harande muzabyiga, ariko muri rusange uburyo bavura cancer nuko when it is of high grade iba ifite mitosis nyinshi cyane, low grade igira few mitosis. So kubera ko imiti myinshi batanga itargetinga the cells which are in cell cycle, especially those in mitosis, bituma rero cancer which is high grade it can respond, usually it responds to drugs very quickly as compared to lower grade tumors. So kuvuga ko cancer this one, though it is high grade, more aggressive, it usually responds to drugs more quickly than these ones. And you will see that usually the lower grades one, they don't treat them using drugs, meaning the medical treatment. They usually use radiotherapy or just a surgery. So, but the exception, there are high-grade tumors which do not respond to drugs. So the clinical manifestations. So clinically, how would you distinguish benign from malignant tumors? So I think these are pictures we have shown in the morning. So this is well circumscribed on the left, so benign tumor. This is not well circumscribed, it destroys around surrounding tissues, so in cancer. So this is a table summarizing everything here in very few words. So the model of growth for benign tumors, they are expansive. So zikura zisunika, mu gihe cancers zikura zisunika cyangwa se zigashwanyaguza, infiltrating. Benign tumors are encapsulated. These malignant are not. So for the rate of growth, the benign tumors grow slowly, rimwe na rimwe zinareka gukomeza gukura, ariko ntiva, ubwo ni irreversible. Ikagumaho iri ntiyongere gukura, ariko ntivaho keretse nyine uyibaza. Mu gihe malignant tumors or cancers, they grow very rapidly and they are progressive. They never stop growing unless you treat them. So distant spread or metastasis, benign tumors, they don't metastasize. Malignant tumor, they most always metastasize. Of course, if there's exceptions, here, pathology. And the results, benign tumors are rarely fatal, while the malignant tumors are always fatal if untreated. So rarely fatal here, we saw the example of benign prostatic hyperplasia. Hari n'ibindi harimo umuntu ugira leiomyoma, a smooth muscle tumor which is benign within the artery, renal artery. So iya bigize muri renal artery, kidney irafailing. Renal failure, this is rare and indirect. So how do we diagnose cancer? So we combine them. Can you mute your microphone? So we combine the clinical history and examination. don't jump to give a diagnosis or to examine if you have not asked about the history. History of the patient is very important. So I can give you an example. Just last week, we had a case. After lymph nodes with a tumor. Then we saw that it was a carcinoma. Ariko ntabwo twari duhawe amakuru ahagije. So turavuga twabonye ko afite carcinoma muri lymph node. Of course, lymph node ntabwo ira epithelial cells. There is no carcinoma in a lymph node unless it is a metastatic. So we said it is a metastatic, and we could not say it is from which organ. So we said we reported that the clinician must look for the primary. Then barampamagara urambwira ngo urumva ngo tumurwaye twamusuzumye tubona afite ikintu muri tiroide ngo dukeka ko rero ari metastase muri kanwa nase ko muba mutabitubwiye. So now so if that is the case dufite immunohistochemistry procedures we can do to confirm that this is from the thyroid. Urumva ntabwo twashoboraga kubikora udafite orientation. Byasaba uko ukora test zirenga n'igihumbi kugira ngo umenye aho aturutse. Amafaranga menshi nta n'umuntu ashobora kuyiha. Ariko iyo bakubwira ati dukeka wenda thyroid n'ikindi kimwe, we have antibodies we use, then we can easily look if it is from thyroid, from the lung and so on. So okay, biroroshye noneho tuzakora immunohistochemistry. We will confirm if it is coming from thyroid or not. If it is not thyroid, they must continue to look for the primary. So they combine with radiographic analysis, X-ray, ultrasound, CT scan, MRI, laboratory analysis. There are things which are called tumor markers. So you will read in the books. So tumor markers no kuvuga buri tumor ifite ibintu irekura za antigene mwavugaga n'ibindi, ariko hari n'ibigenda mu maraso cyangwa ukagenda muri urine cyangwa muri cerebrospinal fluid. So when you fashe samples aho ngaho bitewe n'icyo ukeka ugapima ukabonamo izo factors, then we confirm. Uzamubona muravuga ngo okay, umuntu se twareba human chorionic gonadotropin n'ibizamutse mu maraso umunze kwigamuka iyo umuntu atwite, ariko niba adatwite akaba izamutse nyine nuko afite cancer, cyane cyane cancer yitwa choriocarcinoma. So it is a carcinoma arising from the placental tissue. Ariko no mu bagabo si ngombwa ko ari placenta nya placenta, tissues looking like a placenta. Undi ukaba ati turakeka ko afite ovarian cancer, ukaba atereka dukore marker yitwa CA125 cyangwa 125. So that is a marker which is known for ovary. So muzi ko prostate ikora there is a prostate specific antigen. So ikorwa na prostate. Ku bagabo bafite prostate cancer cyangwa BPH, benign hyperplasia, irazamuka. So this is also a marker of prostate cancer. So there's a tumor markers that are analyzed in biochemistry laboratories, in hospitals, cyangwa se muri immunoserology. It depends on how the laboratory is set. So these are the tumor markers. So they can orient you about knowing what cancer may this patient be having. So then you go to cytology, for example, final node aspiration, where I took a small, just individual cells and analyze them and confirm if there is abnormal cells or not. Or Papa Nicolau smears, which are taken from the cervix of a woman during colposcopy. There is a biopsy. Biopsy is just taking a small part of an organ or tissue. It can be incision when it is small, or excision when you want to remove the whole region. We call it excision biopsy. Then you do histology, where you stain by hematoxylin and eosin and some special stains, or the markers, immunohistochemistry, as I was mentioning about the thyroid. So other possible way of making a diagnosis is through autopsy. So meaning that you have failed to know the diagnosis before death, but you can diagnose after death. Kakuwa ngo bimaze iki, icyo bimaze bitranchiriza umuryango wasigaye bavuga ati at least tumenye icyamwishe, niba ari breast cancer cyangwa se ovarian cancer, bakamenya ko probably in the family they have that problem, noneho basigaye bakazaba careful, bakazaba bakora screening. So in all, the pathological diagnosis is the golden standard one. So when the pathologist say the diagnosis is this, usually there should be no other comments on that. Everybody must accept that. So I think this I had presented the last time. So what is the management of tumors? You must know that the management of cancers is multidisciplinary. Nobody should handle a cancer case alone. So there are physicians, internal medicine and pediatrics, for example, surgeons, including gynecologists and so on, laboratory tests which will be done, the radiologists who will come in, pathologists and the oncologists who give the drugs or radiotherapy. Then there are times the treatment is no longer possible for curative intent. Then you send the patient to palliative centers. Ngo mu Rwanda irahari ya hafi Rusororo niho iba. So abarwayi bageze ko niho bajya cyangwa se bari ku bitaro bya Kibagabaga niho bakunze kubajyana. So bafite imiti igabanya uburibwe ikomeye cyane nka morphine babaha n'ibindi bita ku buryo aba bafite abantu babitaho banahugukiye na palliative care. But in all this, there is family involvement, organization, the survivors of cancers, they help much in stabilizing the new patients, bakabigisha ati humure mufata imiti natwe byatubayeho muzakira, barafasha bakabaha morale kandi morale irafasha. So you see that there are many people who are involved in this. And that's why whenever there is a case who confirmed to be a cancer, or when the pathologist say this is a cancer and they precise, where there is a meeting, we call it a tumor board, where we meet and decide what to do for every case of cancer. In some hospitals, other hospitals, they don't do. So what are the treatment options? There is a surgery. So kuva ku umuntu abifata ibi byose ahubwo ni options. Either surgery, either chemotherapy, either radiation, either immunotherapy, targeted therapy. So as here, I have written here, either one option or any combination. So you can combine surgery and immunotherapy, or chemotherapy and radiation, we call it chemoradiation and so on. Angagenda bivanga none urafata imiti ejo radiation, kandi ntabwo ari imiti ufata kenshi ntabwo ufata buri munsi, ni byo bita cycles. Baravuga imiti ya mbere uzafata wenda mu minsi 4 intensively, utahe ugenda utegereze nyuma y'ibyumweru 2 ugaruke cyangwa y'ukwezi. So buri cancer ifite protocol yayo, buri cancer ifite protocol yayo. Of course ntabwo byose hano mu Rwanda zivurwa, hari izo tubona ibitaro batanga drugs abantu yo ntabwo tuyakira, hari iyo tubona radiation akavuga no iradivesi cyangwa se ntacyo radiation yamumarira. Ikindi navuze nuko habaho gukorana, nuko iyo tubonye umurwayi akenshi let's say afite n'umwana ufite nephroblastoma, so when it is confirmed ifite ikintu cya mbere gikorwa hano mu Rwanda. So hari protocol ebyiri tuzabigarukaho. Can you mute yourself? People should be serious. So when we, for example, have a case of nephroblastoma, the first thing to do, they give radiotherapy. No, chemotherapy. They give drugs so that tumor may be downstage, meaning if it was advanced, it can shrink. Then after shrinkage, icyo gihe ariko babumvikana bati twebwe rero uyu mwana tugiye kumushyira ku miti wenda turayimuha amezi 3, itariki ni agomba kugaruka se yashika mukamubaga ko wenda ibutaro batabaga ibintu biremereye. So ubwo saje kaba mu programme ko umunsi n'uyu tutaba uyu mwana nibwo azaba, kandi bikabizwa namara kubaga histology pathology bagomba kwihutisha igisubizo ku buryo wenda mu byumweru 2 cyangwa icyumweru kimwe kiba cyabonetse, then akongera agasubira gufata imiti cyangwa se akajya gufata radiation bitewe n'icyo histology zaba yabonye. So nuko nguko ni ibintu bigomba kuba biri programme, ntabwo ari upfa kuvuga ngo ngewe ngo umwana ngiye kwishyira ku miti utavuganye na surgeon niba ku itariki ashobora kumubaga, kuko niba atamubagiye igihe ya miti wamuhaye ishobora kuba isa naho yabaye imfabusa. Kandi niba pathology azatanga igisubizo abatanga radiation bakaba batiteguye nabwo, icyo gihe umurwayi ushobora kumujyaho ingaruka kubera ko azamara igihe kinini atavuwe, kansa ikongera, niba hari sereri zasigaye zayo zikongera zigakura. So everything is tightly controlled in this.
Excuse me, lecturer.
Yes.
Ni iki twe tudafite mu Rwanda gituma kesi za kanseri nyinshi twumva zijyanwa hanze?
Ariko nabivuzeho, cancers ntabwo zose zivurwa kimwe. Hari izo dufite ubushobozi hano bwo kuvura, hari n'izo tutabufite. Ikindi ni uko hari na kanseri muri rusange zitavurwa. N'ahandi hose ujya baragerageza cyangwa se bafite imiti iri mu igeragezwa itari hano, kuko abakora clinical trial research bayikorera aho bashaka. Bati hari umuti turi kugerageza wenda wa glioblastoma turi kwegereza wenda muri let's say muri Nepal no muri Mexique wenda no muri Belarus. So icyo gihe wabikoraho iki? Icyo gihe umurwayi ashobora kujyayo and so on, bitewe na connection umuganga afite ashobora kumwoherezayo, ariko ntabwo ari umuti wabazana hano. So icyo ni kimwe. So hari kanseri zitavurwa rero, zitavurwa ahubwo zishobora kuba zifite imiti gusa iri in trial itaremezwa. Icyo ni kimwe. Hari noneho n'izivurwa ariko ubuvuzi bwazo butaragera hano. Ikindi, hari metode zimwe tudashobora gukora ubu. So for example, patient with leukemia iyo umuvuye bikagaragara ko amaseri atari gushira mu maraso ya kanseri, ukora uko usimbuza bone marrow. So bone marrow transplantation rero hano ntihari. Rero ntabwo bavuga ngo kuki tutayizana. It implies many things. It implies many things, birimo ko kuba uwo murwayi aba arwara ahantu hameze nka intensive care. Ni ukuvuga ibyo Butaro ntishobora kubikora kuko Butaro ntabwo ushobora kuba intensive care unit. Ibyo byagombye kuba benda Faisal cyangwa se Ashika cyangwa Butare cyangwa Kanombe, ariko nabo ugasanga hari ibindi bidahari. So ikindi ugomba kwibuka nuko kuvura kanseri hano mu Rwanda officially byatangiye mu mwaka wa 2012. Mbere byarakorwaga sporadically for isolated case. Ubu nibwo byatangiye n'wajyaho center, ariko maybe muziga public health ubundi itangije program. Ntabwo ushobora gutangiza programme n'ikintu kiri complicated. Buri gihe utangirira ku bintu bishoboka. So nuba ko batangira kuvura batangiye ku ndwara zishobora gukira: nephroblastoma, acute lymphoblastic leukemia, bucket lymphoma, zazi n'undi zizweho zishobora gukira kugira ngo beseye barebe. So ntabwo bari kuvuga ngo ugiye kuzana za kanseri n'ahandi zabananiye ngo abe gitangira. So icyo mbivuga nuko u Rwanda rwatangiriye ku ndwara rufite ubushobozi bwo kuvura. And there is a protocol yo muri 2014 ya Rwanda Biomedical Center na Ministry of Health yerekana kanseri 13 priorities u Rwanda ruri gushyira, bagomba gushyiramo imbaraga kugeza mu mwaka wa 2020, mwaka wa 2019 zari kanseri 13. So ni ukuvuga rero niba ari umurwayi ufite indi kanseri ntabwo byashobora kumuvurira hano, yagombaga kujya mu mahanga. Ngira ngo nuko nabisobanura. There is a public health issue management, and of course the case you cannot manage here because of our facilities. Izisaba transplantation icyo twabikoraho. Muzi ko mwabonye ibinyamakuru hano muri uyu mwaka mu mpera hazatangira transplantation of kidney, ariko ni kidney bitajyanye na cancer, bagize failure bisanzwe. So transplantation ntabwo ari ikintu cyoroshye na gato kugikora. So nyirango niyo mpamvu. Otherwise ariko hari n'abajyayo wenda kubera bavuga bati mfite amafaranga menshi reka njyeyo mu mahanga, cyangwa se ntabwo ndi kwemera ibyo bambwiye hano. Baye tubabona benshi ukamubwira this is a cancer you have, okay, akavuga ati okay ni mumpe biopsy yanjye tissue block ngende, akaya mu Buhinde amubwira ibyo ngibyo, bagahitamo ngo ati nta n'ikindi twagukorera, tubiri wanyu bazajya bakurikirana ibyo turabibona kenshi. So hari abajyayo ku bushake bwabo kubera bizeye ko hari icyo babonayo batabona hano, hari n'abajyaho kuko gihari nk'uko nabivuze hano tudashobora gukora ubuvuzi bwacu butarageraho. N'urugero nk'umuntu yagize metastase hano kuyibona ni MRI cyangwa CT scan, ariko MRI cyangwa CT scan yifata iyo kabaye kanini, ariko hari ubundi bita PET scan bukoreshwa aho akantu kari radio active ukakohereza mu mubiri aho gasanze ya kanseri yose gahita gaflashinga ukabona aho za selile ziri. So ubwo bivuga ko hari igihe dushaka ko umuntu adafite metastase hano, ariko aho bafite PET scan yajyaho bakabona ko hari uduserire turi undetectable by MRI, bo bakatubona twebwe tutashobora kubona ko tudafite PET scan. So there are many reasons. And of course ntabwo igihugu kuko kugenda kwabo bivuga ko abenshi bamwe ni leta ibohereza, leta ifite vision ntoya y'abantu ishobora kohereza mu mahanga. Hari aho bikunda kandi aho nabo hari guidelines, hari inama y'abaganga iba ihari igenda ivugururwa ishinzwe kohereza abarwayi mu mahanga. So baba bafite bati aba kanseri ushobora kohereza ni abatarengeje amafaranga, ibibazo by'umutima cyangwa impyiko baba bifite ibyo ngibyo. So hari ibintu byinshi baba consider no bakaba bati ntabwo bigishobotse rero ko hari undi twakohereza uyu mwaka kwako bije yararangiye, budget yararangiye. Cyakora hari igihe uri umuganga ufite collaboration n'abandi baganga bo mwikaye cyangwa mwe muri research, ukabwira you have a case, you have no longer funds, what can you do to help us? Ikindi nibwira hari umurwayi ubushize 2020 twabonye afite leukemia, blood cancer. So ariko mu kuyireba sanga ni imwe muri kanseri zishobora kuvurwa, bizwi ko ivurwa igakira. Unfortunately hano ntabwo dukunda batugeraho bapfira iyo ngiyo ntabwo tubabona. So rero yari yatugeze turabibona ko ari. So the next step yari kuvuga ngo biragenda bite. So dusaka imiti mu Rwanda, dusanga imiti ntayihari koko ntayihari, kandi ayibonye yashaka gukira vuba ako kanya. Ni indwara izwi mu bwoko bwa leukemia ikira ku buryo bwa vuba cyane. So turabaririza dusanga hari imiti, hari imiti iri muri Kenya yashaka kumuvura, tugira famille babyirukankemo bayizane. Okay, barayizana imiti, umurwayi arayifata. Umwaka ushize yaje CHK, numva baramamagaye ngo umurwayi agushaka ngo wakore diagnosis of cancer. So ngira ngo ndagiye kumbwira ko navuze ko ari cancer atari, sanga nuwo ngo ari kwishima Imana ko yakize bundi kubera iyo miti yabonye. Byumvikana ko hari ibyo tudashobora gukora ariko twakora, ngira ngo hajemo n'ikibazo cya procedure, kubera ko niba leta yavuze ngo leukemia zose, myeloid leukemia ntabwo zivurwa. Ibyo babikoze wenda nk'abantu ba public health, ariko iyo wenda iyo baba batubaje nkatwe kandi no hari n'imwe ishobora kuvurwa umurwayi agakira burundu kandi bya burundu, ntabwo biba byagenze gutyo. So uwo ngo yarakize, nubwo yarambwira ati numaze gukora control inshuro nyinshi nta kantu na kamwe kagaragaza ko ari malignant cell ngifite. Ubu cyakora twasabye ko birimo bihinduka muri protocol, iyo ngiyo bakayishyira mu zishobora kuvurwa bityo n'imiti yayo ikinjira mu gihugu. So ahanga niho aba scientists, clinicians n'aba politicians baba bagomba gukorana kugira ngo bagire ibintu bavugurura, for the betterment of the patients. So is your question answered?
Yes, lecturer, thank you.
Okay, thank you. So the outcome will depend on the stage of the cancer. Niba ikiri hafi biroroshye ko yakira, niba iri advanced akenshi ntabwo ikira. So uzayivuga ngo this patient is having advanced cancer, usually yari stage 3 cyangwa 4 bavuga ko ari advanced. Yari stage 1 or 2 bavuga ko iri localized. So localized usually bivuga ko ashobora no kuvurwa na surgery. Ariko ibingibi nabyo hari abantu bibwira ko wenda bazi ibintu byose, akaba ati giye umurwayi namubaze neza, margin zire n'aba pathologist bemeje ko ari negative, ntabwo ari ngombwa ko mu imiti. This is very dangerous. Bimaze kubibona inshuro ebyiri, hari ibyo nabonye ndi muri residence aho nigiraga. Umurwayi yaraje afite tubona afite leiomyosarcoma mu kuguru. So margins were negative. When we went for tumor board, the oncologist said, no, I think if the margins are negative, this is a sarcoma, the patient can just go home. Nari umunyeshuri n'abana ariko giye uko nabibonye muri literature bavuga ko abarenga 60% nubwo bagira margins which are negative for this particular tumor, nyuma y'igihe gito bagira metastasis utaza ahantu. So arabipinga ariko umurwayi ntabwo ko byatinze amezi 7 cyangwa 8 yagarutse ari muri end stage, yafite metastase mu bihaha and so on. So bivuga ko ntabwo ushobora kuvuga ngo jewe I'm sure I have removed completely the tumor and the pathologist confirmed that the margins are negative, ngo uvuge ngo umurwayi ngo ntakeneye imiti. Kubera iki? Nasame hari amaseri yaba yaratambutse ari undetectable at that time. Ariko aho hagiye nyuma zakura agaragaza tumor anica umurwayi. Mwabona iyo margin ari negative agomba guhabwa imiti iyo imiti ihari. There are exceptions that some tumors which are known not to metastasize aho singombwa ko imiti, but otherwise you have to give drugs zizajya gusirive mu biri yose zari ko nta n'akamarigina cell na kamwe katambutse iyo miti iticira aho kare. So the degree of invasion and metastasis, so the type of cancer, of course, the cell of origin, the grade, I have explained in the molecular differentiation, all these are the factors to have a cancer cured or not. So for the prevention, hari education and healthful habits, kureka itabi, gukora physical activities, guhindura diet, energy balance, kwirinda kuba obese cyangwa kugira overweight, kwirinda izuba rikaze, cyane cyane byo ku manywa arimo ultraviolet nyinshi, cyangwa abafite smartphones bisigaye bigizanamo muri byawe za bakakubwira ngo umunsi hari izuba, hari ibicu, ariko banakwereka ultraviolet rays bagita index. So byose bitetse. So hari cancer chemo prevention, kwa ni imiti mina ushobora kunywa kugira ngo to prevent cancer. Of course we don't have them here, ariko imwe turayifite indirectly. Niba imiti ya hepatitis C uyinyoye bimuproteja kuzagira cancer y'umwijima, akaba ari nka chemo prevention. So most important, they are screening methods. Nabivuzeho ko there is the instruction from the Minister of Health in 2014 yasabye ko yategetse amavuriro yose harimo na za mituweli ko zemera umuntu wese, umugore wese ufite imyaka 35 n'umugabo ufite imyaka 40 kuba inshuro imwe mu mwaka yajya kwisuzumisha ntacyo arwaye aho bagiye kureba uko ahagaze ku kintu icyo ari cyo cyose. So that is an opportunity for screening for anything. You think about the cervix, you think about the breast, you think about prostate, stomach, colon, and so on. Icyo ari cyo cyose bakagikorera screening bakareba. Of course, ibifite protocol ntabwo ari uguhita ujya ibyo habanza gusuzuma kare. Niba ari reasons, then bakagukoresha test runaka. There are vaccines nk'iya HPV, cyane cyane niyo twavuga n'iya hepatitis B. So these are there which can help. Ariko abandi bagirana n'imiti vaccine zirinda cancer runaka, nk'iya tuvuge cancer ya melanoma. N'ibihugu bifite melanoma nyinshi nka Australia, iyo miti barayikoresha n'uko imiti mu bushakashatsi ko barayikoresha. So in Rwanda then, nagira ngo twabivuzeho, we look for the patient history, clinical examination, laboratory investigation, tumor markers zikorerwa mu bitaro bimwe na bimwe. Ikibazo twagera stock out bimwe na bimwe ntibikorwa kubera reactive zabuze. Radiation, we have a few radiologists, but ultrasound ziri mu bitaro byose, x-rays mu bitaro byose, mammographies mu bitaro bimwe na bimwe. Kuvuga iyi ngiyi ni nka radio yagenewe breast. CT scans zirahari, nubwo zikunda gupfa ariko at least zirahari. MRI zirahari nkeya, and so on. So pathology labs nazo zirahari. So this is for diagnosis. For treatment, navuga ko abenshi bavurirwa i Butaro iyo ari imiti radiation i Kanombe, kubagwa akenshi ni CHK n'ikorana na Butaro, ariko hari n'abava i Kanombe and so so nuko procedure imeze bijya haba hari itinerary umurwayi azanyurwamo. Ubu hari n'abantu bashyizweho abanasezi bashinzwe kumenya ngo uyu murwayi ku itariki ni koko azabagwa according to the protocol, nyuma y'iminsi ingahe ese azabona pathology report, nyuma yo kubona pathology report ese koko imiti azayitangira. Ibyo byose bakabimukurikiranira kubera ko byagaragaye ko hari studies zakozwe nko muri Dar es Salaam, basanze abarwayi baje kwa muganga, umuntu washoboye kwiga arihuta akabona serivisi kurusha utarize, kandi bidatewe n'uko ari ikimenyane. So ni study I read it. So na hano kandi bijya bigaragara kubera ko niyo bamurangiye bati jya kuri farumasi usobanukiwe ahita yirukana, undi akabanza kuzenguruka ibitaro byose akabaza uwo atagomba kubaza nawe akamuyobya. So ibyo byose birahari, niyo mpamvu hagisizwaho abo bantu nibagize izina babitego, ni abantu bashinzwe itinerere y'umurwayi bakamenya ko anyuze mu nzira ya nyayo, adakererewe kuzabona services. So we have a national policies, ngira ngo nanabivuze ko buri myaka ibiri bahamagaza aba specialists, medical specialists in different fields, bagaterana bakora revision of the protocol. Twavuraga breastfed ubutaka uti okay, MRI ubwo zatangiye kuboneka reka duhindura ibi n'ibi, cyangwa se muri histopathology hari molecular studies bashobora gukora, noneho reka tubyonye muri protocol, then biganasaba ko ministeri ibishyira mu bintu byishyurwa na mituweli and so on. So ni ibintu byose bigomba guhuzwa, ntabwo so ushobora kudesida ngo genzanye molecular studies uyu munsi ngo zigomba gukora. You must consider health economics. Niba utabikoze ngo be integrated mu bintu mituweli ishyura, ibyo biba byafeyirinze. So mpamvu izo nama ziba ari ngombwa. So available options zirahari: surgery, chemotherapy, radiotherapy, immunotherapy, ariko zirahenda ni nkeya. Targeted therapy nka tamoxifen, uyu ni umuti uhabwa umuntu ufite estrogen receptors which are positive, cyangwa se progesterone receptors. So yawuhawe agira prognosis nziza. Nyana umuti bafata imyaka 5 cyangwa 10 utagira complications, side effects ni nkeya keretse iyo batitangira. Herceptin cyangwa trastuzumab niyo navuze, baha umuntu wagize human epidermal growth factor receptor positivity, uhenda miliyoni 70, ngira ngo nabivuzeho. So uyu nawe urahari, ariko nacishemo akarongo kubera ko ntabwo leta yakoraga subvention ko umuntu yirwanagaho kandi ngo ubone, and it is still there, nubwo ari medical insurances nkeya zatangiye kubishyura. So palliation ikorwa na trained nurses, cyane cyane ku bitaro bya Kibagabaga ndetse n'iyo inzu prive iri hafi y'Ikabuga. So multidisciplinary management tumor boards, as I said, we have them. So also we standardize our services, ntabwo dukwasanye ahubwo dukorabora n'abandi kumenya za nama tujyamo, koresha ibitabo bya WHO cyangwa guidance of WHO. Rimwe na rimwe hari aho usanga tutayikoresha ahubwo tugahita tuba okay, kuri iyi system tuzakoresha wenda hari system yabaye developed n'Abafaransa cyangwa Abanyamerika cyangwa Abongereza, tukagendera kuri iyo bitewe niyo tubona idufasha bitewe na settings turi. So but when we report cases, we always refer to the protocol we have used. So mpamvu uzasanga hari igihe twandika ngo CAP is the College of American Pathologists, ntabwo dukoresha protocol cyangwa tugakoresha WHO and so on. But we make sure we go international, kugira ngo niba n'umuntu agiye ajyanye n'iyo report hanze cyangwa ubuvuzi hanze, so we should speak the same language. So we adhere to international organizations such as this International Academy of Pathology and so on. So that's so in general. Any question?
No question.
No question or question? Okay, so if no question, maybe we can take a short break of 10 minutes, then we come back for the molecular basis of cancers to end this chapter on neoplasia.
abasore basigaye bashaka guteze mu muvandi bafite nk'imyaka ingahe kada yawe yakabije none ubundi wakabije sibyo wakabije ukuntu byumva wakabije ariko nabwo wananiranye iwanyu barihebye ngo bagushije ishyano 35 umugabo ariko avuze umukobwa umukobwa anytime.
Okay, so I hope you can see the screen.
No. Yes.
Do you see the screen?
Yes, we are seeing it, lecture.
You are seeing it?
Yes, yes.
Okay, so let's proceed. So we'll be quick. It is like a repetition of what we said, but there are some details here. And actually, this is what will distinguish you from other healthcare professionals, because when we teach pharmacists and those in other fields who are not doctors, we don't focus on this. So, but you must understand this as a scientist, as doctors. So, molecular basis of cancer. So this is the content, introduction, proto-oncogenes. And here we shall go back to concepts of molecular biology that you have learned so that you can understand better what we are looking here at here. So tumor suppressor gene, genomic instability, limitless repetitive potential. I think these things I have presented them as the seven hallmarks of cancers. So they have their proto-oncogenes, they have a self-sufficiency, and the cancer cells, they don't respond, or they don't respond to the tumor suppressor genes. They acquire genomic instability because of they lose the potential to repair for DNA repair mechanisms. So the limitless replicative potential, and they have angiogenesis, and they have a capacity to invade and metastasize. So these you have seen before, but we here more spend the time on the proto-oncogenes and tumor suppressor genes. So this definition you have seen of carcinogenesis, that some call cancerogenesis. This you have seen that there is a malignant cell which is transformed, a malignant change in a target cell which is called the transformation. Then the growth of the transformed cell, which means cell division of that mutated cell, local invasion, and metastasis. This also have seen that the way the tumor, the cell doublings until we have a clinically detectable tumor. So the rate of tumor depends on the growth fraction and the degree of imbalance between cell production and cell loss. So, and this is important. So to have a tumor growing very quickly or slowly, it depends on the fraction of growth and the degree of imbalance between cell production and cell loss. So usually, there is the production is higher than cell loss. That's the reason why the tumor keeps growing. But when you give drugs, usually it regresses. It regresses until it is no longer detectable. Ntabwo ari ibintu byo muri theories gusa. Here we see it. Hari abarwayi baguhamagara bati ya tumeri mwambonyemo ubu ngubu natangiye imiti, ubu ngubu yatangiye kugabanuka, hashira amezi bati ubu nta nebwo ntiyumva, ariko imiti nzayikomeza. So this happens. But if not treated, then it keeps growing. So the growth fraction is the proportion of cells within the tumor population that are in the proliferative pool. So during the early phase of tumor growth, most of the transformed cells are in the proliferative phase. There is a diagram to explain this in the next slide. ngira ngo ikindi mubona ni uko tumor hari uburyo yandikwa inshuro, hari aho bashyiramo EU, hari n'aho batayishyiramo. So this is a British English. The American English, they don't put these units. So I think that you know. So now this is showing we have a transformed cell. It divides, giving rise to daughter cells, other cells, and this cell. And that so this is a proliferative tool. They are just proliferating. Ariko nubwo bimeze gutyo ntabwo cells zose zavutse zikomeza gukura. Hari some they undergo death, so apoptosis or necrosis, depending on the reasons. So others they enter into GO phase, meaning that they are no longer in the cell cycle, they are resting. Others they differentiate. Ahubwo yamukomeza kuba undifferentiated cancer cell igahinduka differentiated. Ndetse uzasanga hari imiti ikorwa bakakubwira ati uyu muti uburyo ukora ni ugufasha cancer cells to become mature. So when they become mature, they become like a normal cells. They are no longer harmful. So icyo ni kimwe. Hari izindi zica amaseli yawe, ibyinshi bigica cancer cells imiti ikoreshwa. Izindi zigatuma zira cells zijya muri GO phase. Icyo gihe birumvikana ko niba nyinshi zigiye muri GO phase, izindi zikaba differentiated, zikaba dead. Muri proliferative pool hasigaramo nkeya, nibwo rero tumor igenda igabanuka ikaba yanashira. So ibi bishobora no gukorwa spontaneously nta miti umuntu ahawe, but this is a chance. Ni chance iba ku muntu gusa akagira cancer ikaregressa igashiraho. Bijya bibaho ni ubushize nabivuze n'umuntu wari wese mu gihe cyayo cyose aba afite some mutated cells and maybe some small cancers, ariko umubiri uteye na immunity uko ikomeye ikazimara. Ariko hari umurwayi wigeze kuza sashika yari afite cervical cancer, very aggressive one. It was terrible. Arataha we avuga ko yagiye agasenga hanyuma aza kugaruka muri control. Ntabwo washobora kumenya ko umuntu yigeze agira cancer, habe no kumenya ko yigeze agira na inflammation. Everything was cleared. The service was looking like a child, if you can say so. So the tumor had completely disappeared kandi ntabwo yari yahawe imiti. So it is possible that our immunity can do it. So the molecular levels of carcinogenesis, nibyo bintu twavuze kare, hari tumor growth promoting genes are called protoncogenes. Growth inhibiting genes are tumor suppressor genes. Genes that regulate programmed cell death, for example, apoptosis. This is the p53, and the gene is involved in DNA repair. So usually a tumor arises when there is a clonal growth of cells that have encoded mutations in 4 regulatory classes of genes. So ntabwo ko buri gihe umurwayi afite ibibazo muri izi genes zose, muri izi classes zose ashobora kugera muri one class. Gusa hari ikibazo gikunda kubazwa, one mutation, is it enough to cause a cancer? So the response nowadays, scientists, they tend to say no. Abenshi bavuga ko muri cancer byanze kunze habamo mutations nibura 3. So this is what people they say, ariko ntabwo ari ihame ko ariko babimeze. So nibyo abantu bavuga, kandi ntabwo buri cancer n'ubundi abantu bayipima ngo bareba amagene bagire sequencing. Ko sequencing irahenda umara igihe nta n'ubushaka kubikora buri kuri mu murwayi. It is not possible. So protoncogenes, these are genes that encode proteins that involved in the promotion of growth and division. I think I had explained this morning. So carcinogenesis occurs due to gain of function mutation in these genes, such the protoncogene mutations are dominant mutations. So gain of function, no kuvuga iyo habayeho mutation muri protoncogenes, ntabwo protoncogenes itakaza umurimo wayo yari gukora, ahubwo umurimo uba uriyongera cyane. Niyo mpamvu ari gain of function. Nicyo gituma iyo habayeho mutation muri protoncogenes, ntabwo serire nanubwo gukura, ahubwo irakura birenze. Mu gihe it is opposite for tumor suppressor genes. For them, when they have a mutation, it is the loss of function. Kuko ubwazo zishinzwe kurwanya tumor, when they are mutated, then zitakaza function yazo yo kurinda ko haza cyuma ahubwo kimikaza. So it is the opposite to this. So here gain of function, and it is a dominant mutation. In the tumor suppressor gene, it is a loss of function, and it is a recessive mutations. So mutated proto-oncogenes are called oncogenes. This I had said in morning. So the mutations leading to formation of oncogenes include chromosomal translocation, point mutation, and amplification mutation. This is important. Chromosomal translocation ukuvuga ni igice kinini cya chromosome cyacitsemo kijya ahandi. Hari igihe usanga igice kimwe cyawe chromosome nk'icyenda kigaye kuri 22, icyo kuri 22 kikajya ku 9. Cyangwa se bikihuza bigakora kandi chromosome kadasanzwe. Iyo bakunda kwita chromosome ihuza igice cyavuye ku 9 na 22 bayita Philadelphia chromosome, iboneka muri chronic myeloid leukemia. Ni nayo navugaga abantu bajya bareba ko barwaye runaka bayifite bakaba bamuha umuti specific wo kwica seli zose zagize icyo kibazo. So point mutation ni handi ahari adenine isimburwa wenda na guanine cyangwa se tyrosine cyangwa se cytosine. So that is a point mutation. Ariko ishobora no kuba atari replacement, ahubwo habayeho deletion cyangwa se addition. Insertion, there is an insertion or a deletion of a nucleotide cyangwa se ebyiri cyangwa enye, which are not multiple of 3 usually. So amplification mutation ni igihe hari gene cyangwa igice cya gene cyagiye kigaruka inshuro nyinshi, cyagombye kuba ari copy imwe ahubwo kikaza ari many segments. So that will be amplification. Ikindi navuze cyo ni gishobora kubaho ikindi ni overexpression. So gene uko ingana niko yakomeje kungana, ariko niba ari receptor igahora iri activated, kandi ubundi yo itari gukora yagombye kuruhuka ntimenyekane ko inahari. Yo igakuma kuba activated yohereza information in the nucleus. So that it is not structural, so ntabwo tubifitemo hano. So ngira ngo ibyo tugiye kunyuramo hano ni ibyo mwize muri genetic disorders cyangwa se muri molecular biology. So disorders due to aberration of host cell genome, aberration. Yes.
Sorry gato kuri nuze kuri zira causes zitera iriya proto-oncogene. Tumaze kubona kuri ya chromosomal translocation. Ntabwo ndi kumva neza ukuntu chromosome yabaye separated, ukuntu nyine igice kimwe kirakomeza gukora nyuma y'uko cyacitsemo, rwose ntabwo ndi kubyumva neza.
Okay, ariko ibi mwarabyize muri cell biology cyangwa muri genetics. So let's take an example of bucket lymphoma I explained in the morning. Uko yavutse, ko bayibonye muri Uganda and so on. So when you go to molecular, byasanzwe ko muri Sweden babibonye ko hari chromosome, a part of chromosome 8 is iragenda ikivanga na part of chromosome 14. So consequence ibaho ni iki? Nuko gene yigiye, gene ishobora kuba expressed whenever ni DNA iruzuye. Nibyo bita promoters ziba zibanziriza gatoya kenshi birajyana, ari byo bituma iba expressed. So no kuvuga ni nko kuvuga ngo kuba ndi umuganga nkava hano nkajya Burundi cyangwa nkajya mu kindi gihugu ko natakaza status yo kuba umuganga. Ntabwo ari byo, mba ndiwe. Niba ari gene igiye iri full, irakomeza akazi kayo aho igiye hose. Ahubwo ikibazo aho igiye izakora iti. So nko kuri bucket lymphoma ikibazo kiba ni iki? Hari a gene called the c-MYC. c-MYC ubundi ishinzwe transcription. So muri bucket lymphoma icikaho yariri ikajya kuba hafi ya gene ishinzwe IgH. So heavy chain of immunoglobulin. Iyi igezeyo consequence zibaho nuko ku muntu ufite chronic infection nka malaria, niko bisobanurwa. Wa ukenera gukora antibodies nyinshi kubera chronic malaria, ya IgH igomba kuba produced cyane. No kuvuga iyo gene iba expressed buri gihe biri gukora. Mu gukora kwayo kandi ikore antibodies, bituma ya gene ishinzwe transcription yagiye yikitera iruhande rwayo nayo ihita iba ibyara protein ishinzwe gukora. So hakabaho ahanga ikibazo kiba ni overexpression now of CMYC. Yari ishinzwe transcription, none igeze ahantu hahora hari activity hataruhuka, igahora ikora rero transcription. Mu gukora transcription nyinshi numva no gukora za copies of DNA and then copies of messenger RNA. Ibyo bituma rero serire ijya muri cell division cyane. Ari no mpamvu bacteria infoma navuze ko ishobora kwikuba inshuro ebyiri mu masaha 28 kwekora cell division nyinshi naho bikomoka. So icyo gice rero cya CMYC kimukira aho hantu gikomeza akazi kayo. So nta ni ibintu binumvikana keretse uvuze ngo icikiyemo hagati birashobora ko yagenda ntikomeze, ariko nibigiye yose igice kiri function gikora cyatuma transcription ikomeza kikaba cyagiye nyine zakora akazi kayo. So n'izindi translocation rero nuko zikora ngira chronic myeloid ya chronic myeloid yes, anayo habaho upregulation ya system ya tyrosine kinase kubera gene yitwa ABL1 na BCR zihura, noneho upregulation of tyrosine karo. So hagahoraho second messengers zihora zoherezwa buri kanya. So nibyo ngibyo. So okay. So aberration of the host genomes may be divided into two groups. The first group is chromosome aberration, iya kabiri noneho ni mutation. So ibyo mugomba kubyumva, aberration cyangwa se abnormal changes within the host genome cyangwa DNA ziramoko abiri, hari chromosomal aberration. Iki ni ikintu donc ushobora no kubona kuri microscope. Muzajye muri laboratoire ya genetique aho ngaho muri School of Medicine, bazabereka bapima ibintu bya genetique icyo bita cytogenetics. So cytogenetics ntabibona mutation ariko ibona chromosomal aberration. Niba chromosome zabaye eshatu, trisomy, barabibona. Niba hari yacitseho igice, barabibona. Ariko ntabwo ashobora kubona mutation ngo cytosine yasimbuwe n'iki. No, it is not possible. Iyo ni molecular studies. Naho ibyo bakora ni cytogenetics cyangwa se bita karyotyping. So chromosome aberration, it can be a structural aberration. Nukuvuga hari deletion, hari igice cya chromosome cyavuyeho kiratakara, kira dispari cyangwa se kikajya kwitera handa kure cyagiye undi iba ari translocation. Hari inversion, nukuvuga kiracitse ariko gise kigaruka handa ko kigaruka cicuritse. So nukuvuga icyari kuri herekeye ku mutwe kigiye aho twakwita ku murizo. So iyo ni inversion. Noneho akaba na translocation. So these are structural or chromosomal aberration: deletion, inversion, and translocation. So rimwe na rimwe abantu bakunda kumva ko chromosomal aberration zose ari translocation. Ni niryo jambo dukunze gukoresha even as, but it is not true. Nuko tuyikoresha generic ariko translocation ivuga ko ari exchange of two broken regions between two chromosomes. This is a reciprocal one. Hari Robertsonian translocation, there is irrigation of two broken regions and the flowing formation of a new chromosome. Nyangure byo navuze kuri bucket lymphoma, chromosome hari igice kiva kuri 8 n'ikiva kuri 14 bigasimburana exchange. Ubwo no kuvuga wenda igice cya CMYC kiragenda kikitera ahavuye IGH, noneho kwa ko IGH yari ifite promoter ihora ikora, ya promoter igahita itegeka CMYC nawo guhora ikora cyane. So Robertsonian no birumvikana hakorwa a new chromosome which didn't exist before cyangwa itaba muri normal persons. So this is structural chromosome aberration. The second is numerical chromosome aberration, ebye bya trisomy monosome. Wasanga ndafite aga chromosome gatatu kamwe, undafite chromosome 21 afitemo eshatu ariyo ta trisomy 21 and so on. So after the chromosomal aberration we have gene mutations. Okay, nabivuze. So gene mutations we have 4 types. We have a point mutation. Nukuvuga ni hahandi usanga timine thymine yasimbuwe na cytosine and so on. So iyo ni point mutation, ishobora kuba nonsense cyangwa se ikaba missense. So turabigaruka cyangwa mwaranabyize. Hakaba insertional mutation, hari nucleotides zaze ziterwamo, hari deletion, hari zavanywemo, no hari na amplification. Ugasanga hari nucleotides cyangwa se a part of a gene which is coming into multiple fragments or copies. So tugiye muri some details about these mutations. So point mutation is the exchange of one base of a nucleotide with another heterocyclic base. So we have two subtypes, missense. Hano habaho another sense codon. Nukuva hari codon, murayizi codon ni utuntu dutatu, nucleotides eshatu which code for one amino acid. Iyo rero hajeho formation of another sense codon and following replacement of one amino acid with another amino acid in the protein, ibaita missense mutation, point mutation. Non-sense point mutation has a whole formation of non-sense codon. No kuvuga stop codon. Molecular biology, there are codon which are known when they are presented. Iyo ribosome izisomye itimenya ko ubwo proteine igomba kurangirira aho ngaho. So iyo rero habaye ikosa iyo mutation ikaza urabyumva proteine yari gukorwa niyo ku acid amine 200 ikaba yigeze kuri 91 proteine hit ihagaragaho. Proteine ikozwe ntabwo izakora akazi nkako iri normal igomba gukora. So these will cause many problems depending on the function of that protein. So these are point mutation, so missense and non-sense turabirangije. Then insertional mutation, nkuko mubizi ni igihe habayo insertion of nucleotides, especially when they are in multiplication of free. Nukuvuga hagiyemo 3, hagiyemo 6, hagiyemo 9 and so on. Birumvikana ko icyo gihe protein ari gukorwa hagati hazamo indi amino acid idasanzwe. Ariko ukundi ibindi bice bya protein bizabiri normal. Izaba iyo bita frame shift iyo hagiyemo nucleotides zitari in multiple of free, wenda 2, 1, 4, 5, 7 and so on. So icyo gihe okay, it is here frame shift mutation. Icyo gihe protein ari kuzakorwa kuvaho mutation ibereye, ibikurikiyeho byose biba ari ibintu bitari kugeza protein aho izarangirira. Mu gihe muri iyo hejuru insertion of nucleotides which are multiple of 3, ikibazo kibaho ngaho gusa, izindi zikurikiyeho ziba ziri normal amino acid. So that's all for insertional mutation. So for deletional mutation is the same. Here are one or more nucleotides. So consequences anything is only insertion. No kuvuga niba ari multiple of 3, we will not have a frame shift mutation. But when they are not in multiple of 3, we will have a frame shift mutation. So amplification mutation, multiplication of one or more nucleotide repeats or even the whole genes. So this happens, as I said. So the mutation leading this slide we had it before. Nibi butanoneho tumaze kubona prereki. So tugarutse aho twari tugeze imbere. Mutations leading to the formation of oncogenes include chromosomal translocation. Ngira ngo ijambo translocation atwarinda kagira aberrations ko twabonye ko zofatari translocation, point mutation and amplification mutation. So the mutation leading to the formation of oncogene include chromosomal translocation. Iyo zibayo habaho increased expression or increased activity. So usually expression nicho ushobora kubona kuri histology or cyangwa kuri molecular aspect, ugasanga ko a gene is being overexpressed. Hari markers dukoresha ikabikwera. Increased activity if paired with sequences that mask the regulatory domain. So there are regulatory domain in the genome. If these regulatory domains are masked, then the activity of that gene will be always there because they can't be moderated. Cyangwa ntabwo ushobora guhagarikwa ngo zibe zuruhutse. So the point mutation, they lead to increased activity due to mutations and the following loss of regulatory domains. While for amplification mutation, it leads to increase the expression due to multiplication of the proton gene as a whole. This slide, we had it in the morning. Proton genes are in 5 groups: factors or stimulatory molecule, or signaling molecule, because okay, here they are factors, growth factor. So we have a growth factor, they are receptors, or they are secondary messengers, or transcription factors, or cell cycle promoters. And this is what we have seen in morning. Ngira ngo twari twabivuze, especially ahangaha kuri steroids, they will have their receptor inside the cell, while other growth factors, they have their receptors usually at the cell membrane. So here, for example, protein hormone action. So here we have an example of growth factor as a hormone. It comes, it is received by its receptor. Then the system here, it is tyrosine kinase or GTP coupled proteins. They induce the formation of secondary messengers, which will go to induce the multiple biological effects into the nucleus and so on. And for the steroids, such as the estrogen, testosterone, progesterone, their receptor is inside the cell, not at the cell surface. So tugiye kureba rero ingero zazo. So of course they are billions and billions, ariko hano icyo tureba ni ingero kandi ziri pratique tubona buri munsi muri tumors tubona hano. So growth factors, the next we shall see receptors. So I think I've explained them. Ariko izo tushobora kubona ingero, we have a transforming growth factor alpha. You remember we saw this also in healing and repair. It was there. Itera growth or multiplication or cell division. We get transforming growth factor beta, which is the antagonist to this one, if at one tumor suppressor gene in most of the cases. So this is a proton gene. Once mutated, it becomes an oncogene. Kandi igaragara cyane cyane muri za sarcomas, not carcinomas, sarcomas. Platelet-derived growth factor, twabibonye nayo muri healing and repair, ituma habaho new blood vessel formation. It is also seen mutated in glioblastoma. You remember glioblastoma, it is a malignant astrocytoma, if I can say so, or glioma. So the receptors, they include epidermal growth factor receptor B1 and B2, they are many. So they are members, this is a member of epidermal growth factor receptor family. Usually, it's the way it is mutated, it causes overexpression. There is an overexpression of this gene when it is mutated. So it is more seen in squamous cell carcinomas of the lung. So we are having examples in the way which tumor we find them most. So yeah, in the muri breast ni type 2, here type 1, iboneka muri lung. So this is epidermal growth factor receptor B2, ubundi kanitwa HER2 new, naryo jambo dukunda gukoresha ku bitaro when we are looking for breast cancer patient. So it is human epidermal growth factor receptor 2, NEM. So it is a member of this family. It is also the mutation is when there's a mutation in this gene, there's an increased of gene because it is oncogene. So it is more seen in carcinomas of the breast, lungs, ovary, and the salivary glands. So you know, iyo tuyisanze muri breast cancer, every breast cancer tubonye tureba ko afite iyi mutation, tukareba ko afite overexpression of estrogen receptor na progesterone receptor. So ntabwo yagombye kuvurwa adakorewe ibyo ngibyo. So second messengers, cyane cyane ko iyi ngino navugaga kare tujya gusoza presentation yabanje ko iyo ari positive kuri ahabwa wa mutitwa Herceptin wari navuze ko uhenda kandi mituweli zimwe nyinshi zitashobora kubishyura. So now mutation in secondary messengers, mutations in them lead to overexpression and or increased activity of the second messenger proteins. And this, they include RAS. So RAS, this is a G protein, GTP-dependent protein, niya system na imvuga ibiri coupled kuri receptor ari kuri imbere muri ahagana muri cytoplasm, ariyo ituma imenya ngo haje information kuri receptor, then which second messenger should we send to the nucleus. So nibyo bikora, iyo atari iki bikorwa na tyrosine kinase system. So RAS rero ni gene izwi cyane. So usually when there's mutation in it, it leads to increased activity due to point mutation of the intrinsic GTPase leading to failure of GTP hydrolysis in the following constitutive activity. Icyo bisobanura ni iki? Nuko iyo hari message yakiriwe kuri receptor, second messenger igakorwa n'iyi G protein, second messenger ikoherezwa. Normally hari enzyme yitwa GTPase ihitiza ikagira hydrolysis of this G protein kubera ko yari yabaye active. So to hydrolyze it, it is to make it inactive. So ni nko kwicecekesha akazi kanyu karangiye mwe mucecetse. So therefore iyo habaye mutation muri ya GTPase ya enzyme, iyi G protein ikomeza kuba expressed. That's why here it is an increased activity. So ikomeza kuba expressed ikifata nkaho hari andi makuru ari kuza kandi ari ntayo. It is present in 30% of all neoplasms. Ariko ngira ngo ikunda kugaragara kuri tumors cyane cyane za pancreas, amara, ariko n'ahandi henshi yabonekamo. Okay. You can understand pancreas and the colon. So we have ABL. Also, it is another second messenger. Ngira ngo hanga izi system ebyiri twagomba kuzivuga ko hari second messenger zikoreshwa na G protein, hakaba n'izikoreshwa n'iyo bita tyrosine kinase. So harimo iyi rero yitwa ABL 1, hari na ABL 2. Sorry, yafatiye ku muntu wayivuze bwa mbere yitwa Abelson, niwe bafatiyeho bayita gutya. So ikibazo cyaho rero iyi ngi iboneka muri chronic myeloid leukemia. Chronic myeloid leukemia nabivuze ko na sasha twatangiye kuyipima ubu ngubu molecular atari kuvuga ngo ni histochemistry. Nibyo navuze it is a study, ariko bizanakomeza. Twasabye ko bijya muri tarifu za leta. Fortunately tarifu zahise gusorwa na Minisante yahise ijyaho, byahise bijyaho. So mu kuba kubutaha abarwayi zayo bikorerwa mituweli zibishyura and so on. Otherwise twabikoze ku buntu kwa yari study bikorera abarwayi. So usually here we have increased activity due to chromosomal translocation in the following fusion of BCR breakpoint cluster region on chromosome 22, leading to masking of the regulatory domains. So aha niho hakorwa protein yitwa chromosome yitwa Philadelphia, kubera ko chromosome igice cya chromosome 9 kiragenda kikafatana na chromosome 22, hakaba masking of regulatory domains, bigatuma iyi BCR2 ikomeza gukora. Mu gukomeza gukora rero ntabwo igenda yonyine. BCR iba yafatanye na ABL1 gene zigakora icyo twita ni nka transcript, niko bakunze kwita chimeric transcript. Nukuba ni ikigene kidasanzwe, bityo zikanakora protein ivamo ni protein idasanzwe. So iyo protein ubone twe niyo dushaka molecular tukayishaka niba umuntu ayifite mu maraso, then tukamenya ko afite iki kibazo, kuko indwara ibi biboneka muri chronic myeloid leukemia gusa. Then bakamuha umuti witwa Gruvec, yo ata bya bintu bitagabanutse mu maraso nyuma y'amezi tugasanga bikirimo, tumenya ko wenda uyu muti atari appropriate, maybe habayeho resistance, tugasaba ko ahabwa umuti wundi w'iyindi class. So nuko bigenda. Ariko ahangaha ni hakorwa chromosome nshasha kandi ihuriyeho na ABL1 na BCR, bituma BCR itaruhuka ahubwo igakomeza gukora because of the masking of its regulatory domain. So uwo muti utangwa ubundi Gruvec utuma iyi tyrosine kinase idakomeza kuba upregulated cyangwa idakunda kugira increased activity. So apart from messengers, we have a transcription factors. So if izwi cyane ni MYC nayivuzeho kuri bucket lymphoma, ariko iyo muri bucket lymphoma yitwa ubundi C-MYC, hano imbere bashyiraho C. Hakaba niyo muri neuroblastoma yitwa N-MYC and so on. Hakaba so iboneka muri neuroblastoma, bucket lymphoma, breast, colon and lungs. So nayivuzeho ni transcription factor, bivuga ko iyo ibaye mutated, iyo igize ikibazo ituma transcription yiyongera cyane. Kubera this is a gain of function mutation. We are dealing with the conjugates. Now the fifth class is the cell cycle promoters. They lead to overexpression and or increased activity of the cell cycle promoter proteins. So these are cyclin D and cyclin dependent kinase 4. Ni urugero nizo zikunda kugaragara cyane cyane. So umurimo zikora murabizi hano muri checkpoint from G1 to S phase of the cell cycle niho izi zikora izi cyclin D, cyclin dependent kinase 4. Niho zikora no kuvuga ntabwo zemerera ko cell iva muri G1 phase ngo injire muri S phase hakiri ikibazo. Izi ni checkpoint. So ikibazo rero birumvikana niba bishinzwe kugenzura byayo mutated, even a cell having problems will be allowed to undergo mitosis. So icyo bikora hano rero ni iki, hari transcription inhibitor factor yitwa retinoblastoma gene 1, ubundi ngi ishinzwe guhagarika selile ntihite ijya muri S phase uve muri G1 phase. So birumvikana ko ni transcription inhibitor factor, iyi ngiyi iri muri tumor suppressor gene y'ubwayo. Ariko izi za cyclin D na cyclin dependent kinase 4 z'ubwazo ni protoncogene, they are not tumor suppressor gene. Izi ngizi zo zikora zishaka ko habaho transcription. Retinoblastoma ahubwo ikabihagarika, no, let's check first. So the cyclin D mutation is common in cancers of the breast, esophagus and the liver, and the cyclin dependent kinase 4 mutation is common in melanoma, sarcomas and glioblastoma. So nukuvuga ko muri checkpoint mutation ishobora kuba kuri cyclin D cyangwa se ikaba muri cyclin dependent kinase 4 ubwayo cyangwa byombi, kandi iyo bibaye byombi umva risk yo kugira cancer iri ihu. So we have other cyclins and cyclin dependent kinases. We are just giving examples. So ngira ngo izo checkpoints murazibuka, hari iva kuri G1 phase ijya kuri S phase. Okay, so interphase we have resting and so on. First gap synthesis and the G2 phase. We have the checkpoints here. So the checkpoint, as I was saying, it is in G1 phase. Before proceeding to S phase, anga agomba kubaho checkpoint. Seri itaremerwa kujya muri S phase. So hakaza kuza indi checkpoint between G2 phase and mitosis. Here, hakaba indi checkpoint after mitosis. Okay, mitosis yarangiye, selile zitandukanyije, ariko kugira ngo za cell zabyawe cyangwa n'indi yari hari zongere kwemererwa kugira indi mitosis, indi cell cycle, sorry, there must be another checkpoint. So we have 3 checkpoints, G1, G2 and the M checkpoints. Ariko the M checkpoints ntabwo kunda kuvuga cyane. So buri yose refite genes ziyishinzwe zishobora kuba mutated or not. So for example, the G1 phase going to S phase, kwabonye cyclin dependent kinases zibishinzwe, n'ahandi kuva kuri G2 phase ujya muri M phase hari izindi and so on. So examples of cell cycle inhibitors and so on, we have if there is a damage in the DNA by radiation, for example, this damage in DNA will activate protein P53, you know, because it is the oneness. It is surveys, it looks if there is any mistake, any error in the genome. Then if there is that damage, P53 will stimulate the synthesis of protein P21. And this one will inhibit the complex cyclin independent kinase, ibyo bituma replication of DNA ihagarika. So niyo checkpoint ubwayo ni uko ikora. Ariko rero ikibazo ngo na kare nabivuze ni igihe mutation y'ubwayo iri muri P53 ariyo yarishinzwe ibintu byose bihinduka corrupt, byose bikaba ikibazo gikomeye. So P53 plays an important role in triggering the control mechanism at both G1 and the 2 checkpoints. So ngiye komeza kugaruka. So tugarutse hahandi rero twari turi ngira ngo ni cyclin ni ya slide igarutse kwa kubibutsa gusa aho icyo zira cyclin uko zikora n'uburyo zihagarika n'uburyo zifite ibizihagarika nka retinoblastoma gene cyangwa se P53 kugira ngo habanze hagenzurwe. This is the checkpoint. Otherwise the cyclin D and the cyclin dependent kinase 4 zo ubwazo they promoters, they are cell cycle promoters. They are not a checkpoint. They must be arrested so that a check can be taken, and if everything is fine now, be allowed to complete the cell division. So that's all for the protoncogenes. If any question can ask, otherwise we'll go to tumor suppressor genes. Okay, so for tumor suppressor genes, they are anti-oncogenes because their role is opposite to oncogenes. They encode proteins that are involved in inhibition of growth and division. Carcinogenesis will occur when there is a loss of function. Now we say the gain of function. Muri protoncogenes here, they are loss of function, and the mutation are recessive. So for a then mutation to be expressed, both areas must be affected. If you have two hit hypotheses. So both areas must be involved with the mutation in order for that mutation to be expressed. Opposite to oncogenes, whereby one mutation is enough because they are dominant. So the mutations leading to defective tumor suppressor genes include the chromosomal deletion. Birumvikana niba chromosome yarishinzwe gukora niba gene yarishinzwe gukora protein which is a tumor suppressor protein, iyo gene ikaba itagihari, iyo gene niba itagihari, then cancer izaza. So chromosomal deletion of that gene will lead to decreased or absence of expression. Another possible mutation is the point mutation. So birumvikana niba ari amino acid imwe yagomba kuza hakaza indi, the function will be lost of that gene or that protein. Insertional mutation is the same. Nkuko twabibonye hariya muri protoncogenes ndetse nanga deletional mutation is the same. Niba ari frame shift cyangwa atari frame shift and so on. Ariko niba iyo ari yose yabereye mu tumor suppressor gene, ya gene izatakaza function yayo yo gukontorora cell growth. So this is a slide we had seen in morning, 6 groups. So we have inhibitory factors, the receptors, inhibitory factor, receptors, secondary messengers, which are inhibitors, of course, transcription inhibitory factors, retinoblastoma gene 1, and the cell cycle promoter inhibitors, and then P53 itself. So kare twabivuze kuri growth factors, twabonyemo transforming growth factor alpha. Navuze ko beta ari antagonist kuri yo iza muri tumor suppressor genes. So alpha is a protoncogene, beta is tumor suppressor gene. So buri wese afite uburyo yiga ibyo akabi keeping in mind. Transforming growth factor alpha is protoncogene, beta is suppressor gene. So twakubifata alphabetically. So which alpha niyiza mbere, proto-oncogene iza mbere ya suppressor gene muri alphabet, wenda ukabifata gutya. Iyo ushaka kutazibagirwa ibintu akenshi ni uko bigenda. So ntabwo ari ukuboroka, ahubwo ni ukubifata niki gihita kimbwira which is which. So this normally acts by autocrine stimulation. Autocrine, you remember what we saw in the hearing test, means it is produced by a cell and it comes to work, to act on that same cell. So the receptors, we can have the receptors to this same factor, transforming growth factor, beta receptor 2, this type 2 receptor. So this is more seen in stomach, colon, and endometrial cancers. So dufite n'izindi nyinshi, transforming growth factor receptor type 1, type 3. So after receptors, we have messengers, isobeta SMARTs. So these are mostly mutated in pancreatic cancers. Transcription inhibitory factors na nkuko nabivuze kare harimo retinoblastoma gene, bakunda kongeraho 1 kuko wenda hari n'izindi zaje kuvumba. So ngira ngo icyo tugomba kumenya nuko iyi gene nubwo yitwa retinoblastoma yabonwe bwa mbere ko iba mutated ku bantu barwaye retinoblastoma. That embryonal cancer arising from retina. Ariko nyuma byaje kwa ko inagaragara mu zindi cancers, ariko igumana ibibazo. So ntabwo bivuga ko iyo mutated in retina cancers only. So it acts by binding E2F. E2F is a transcription factor. So birumvikana ko iyi ni transcription factor iyo iri muri proto-oncogene. So retinoblastoma gene ikikora ni ukuyifata ikayifunga ikayibuza gukora for G1 to S phase genes. Ni ukuvuga irayifata iyo yifashe iyibuza cell gukomeza muri S phase mu gihe gikorwa checking. Iyo checking irangiye bikagaragara ko nta kibazo gihari, retinoblastoma gene ibwirwa kurekura E2F gene, noneho mutation cell cycle igakomeza. RB mutations are common in retinoblastoma, osteosarcoma, and melanomas. So the cell cycle promoters inhibitors. So we have hariya mbere muri proto-oncogene twabonye cyclin independent kinase. None hano tugiye kubona cyclin dependent kinase inhibitors. 1 and 2 and so on. So it is a member of a cyclin independent kinase inhibitor family. It inhibits all cyclin independent kinases except yakane twabonye iri muri promoters. So it is common in cancers of testicles or testes, ovaries, esophagus, colon, and rectum. Type 2, it is also a member of the same family. It normally inhibits cyclin independent kinase 4, iyo twabonye kari promoter. So therefore, ni inhibitor, ni suppressor. So common in melanoma, glioblastoma, soft tissue sarcomas, cancer of esophagus, pancreas, and bladder, and so on. So P53, yeah, so it normally surveys the integrity of the genome. If it encounters severe irregularities in the genome, it will initiate 3 sequential events. So the first event, it is to make sure the cell cycle is arrested in the G1 phase. Ibyo bikora gute biranditse ahangaha, it initiates the transcription of cyclin independent kinase inhibitor type 2A tubonye ko ari tumor suppressor gene. So icyo ni kimwe see above ko tumaze kubibona. So the transcription of this tumor suppressor gene will lead to inhibition of CDK4 babonye as the proto-oncogene, and then preservation of DNA-bound RB protein and following arrest of the cell cycle in G1 phase. So therefore, P53 umurimo wayo wa mbere ni uguhagarika cell cycle in G1 phase. Ni kuvuga this is a checkpoint. The second one, it is to repair DNA if it encounters any irregularity. This is done by activation of the beta growth arrest and DNA damage 45 in gene. So when now this is not possible, when the repair is not possible, the P53 will induce apoptosis. So there are 3 things. It arrests the cell cycle, it triggers DNA repair, and if all these fails, then it induces apoptosis. By activation of BAX and inactivation of BCL2 genes. So these you have seen in a cell injury, cell death, and so on. So in view of these activities, P53 has been rightly called a guardian of the genome, in this term I had explained in the morning. So if the integrity of the genome is restored before the initiation of apoptosis, p53 will be inactivated and the cell cycle arrest will be removed. So ni ibintu tightly regulated, ubona ko hari ukundi kuboko kwikoresha ko habumvikana ko byibwiriza ngo twasanze DNA ari nzima none reka p53 tuyihagarike ibyo yakoraga tuyibwire hagarike. So ni nkaho hari amategeko bihabwa, wenda ni amategeko bihabwa n'uwaremye umuntu. So mutation in p53 are present in 70% of all neoplasms, including benign and the malignant neoplasm. Ngira ngo tusina kivuze mu gitondo, you will pay attention. Uzasanga umuntu pathologist yavuga ngo we think this person is having a neoplasm. As the doctors, they should not consider neoplasm as a cancer. Neoplasm can be benign or malignant. So hari igihe byagiye bibaho, you report that kuri cytology are not required to give a precise diagnosis. Hari igihe uvuga follicular neoplasm cyangwa thyroid neoplasm. Ibyo ni muri system dukoresha ya PET test ni kwinyi. Ariko clinician akaenda akavuga ati bavuze ko umurwayi afite cancer. But ntabwo ko byavuze. Neoplasm means a tumor which may be benign or malignant. So don't misuse this term. So therefore, this 70% for all neoplasm include the 8 cancers and the benign tumors. But it is more common in the lung, breast, and the colon. So that's all for this. So for the genomic instability, na bivuze ko ari ikibazo cyo mutation. When a mutation involves a DNA repair system, niho bavuga ati abantu bashinzwe kureba ko hari ikintu kitagenda, wenda ba police cyangwa abari nabo ngabo bakaba bari corrupted, numvikana bizakurikira. So these genes involved in DNA repair mechanisms. If these genes are or these systems are mutated, then the person will be at high risk for developing cancer. So if you tubibona mu byo bita hereditary non-polyposis colon cancer. Nyango kare navuze ko hari cancers nyinshi za colon ziva ku bantu bafite polyposis, polyps nyinshi. None hano haje indi syndrome igaragara muri ari familial cyangwa hereditary, ariko abantu bayifite muri family ntabwo bafite polyps. Now that's what it is called non-polyposis. So we have a familial adenosis poly and you have a hereditary non-polyposis colon cancer syndrome. They have a defect in the mismatch repair system and they will develop the carcinoma of the colon. Young patients we saw at Sashika, many of them. So tuzareba niba bafite mutation za hangaha, nidusanga bazifite then abo tuzasanga bazifite. Tuzamenya ko inafite familial problems. Then tuzareba first degree and second degree members of their families, relatives. Tubapime screening for steps zitandukanye, utuntu tutari invasive, abo dusanze ari ikibazo dufate biopsy turebe nabwo bafite izi mutation. Thereafter tuzakora proposal of a protocol of screening these mutations among the population of Rwanda. So another category is abarwayi bafite ibyo bita xeroderma pigmentosum. So twavuze ko ultraviolet light yo mu zuba itera skin cancers, ariko umubiri wacu ufite system yo kurepair, gukora repairing of the mutations. So mutations ikunda kubaho nizo bita pyrimidine dimers, aho usanga umuntu afite twa timine twinshi twaje twitera muri genome kandi ubundi tutagomba kubamo. So umubiri rero ufite uburyo ubikuraho byo bita nucleotide excision repair mechanism. Okay, it is written in nucleotide excision repair mechanism ya pathway. Iyo ni ikuraho twa thymine twiteyemo. Hari abantu rero badafite ubwo bushobozi. Iyo system ishinzwe gukuramo utwo tuntu batayifite kubera y'ubwo yabaye corrupted. So abantu tubita ko bafite icyo bita xeroderma pigmentosum syndrome. So no mu Rwanda barahari. Ikibaranga rero abantu batinya izuba, usanga akana gafite uruhu rwakanyaraye cyangwa bakutse nk'umusaza kubera ibyo byose, kubera uburyo ateye adashobora kwihanganira izuba. Niyo arebye agiye ahantu hari izuba ntabwo areba ahita kumama ahumbye amaso cyangwa yafunga kubera abatinya izuba we ubwe. So ariko bafite risk yo kugira skin cancers kubera ko repair mechanism yabo idakora. So mu Rwanda bavuga ko bahari n'ahandi barahari nagiye mbabona no mu bindi bihugu, ariko icyo navuga hano nuko bafite risk yo kugira skin cancers nk'uko aba albinos bakaba twitaga nyamweru nk'uko nabo bari exposed kugira izi cancers. So leta yashyizeho mechanism zo kubarinda, kubaha amavuta abafasha bisiga kugira ngo birinde iryo zuba. Hari abageraho, hari abatageraho, amavuta akarigiswa, byose okay birahari. Ariko ikindi gihari twifuzaga nuko abangaba bahabwa kuko benshi ni abantu baba ari abana, ntabwo kugeza ubu ntabwo tuzi bakuze ngo abantu bakuru, ni abana bagombye kwiga ariko ntibakwigana n'abandi kubera abandi bajya gukina ku zuba, bigenda ku zuba. So n'abantu bagombye kuba mu bigo aho baba barinzwe ultraviolet rays z'izuba. So hari ubuvugizi bugikorwa together with the dermatologists in our country at our hospital. So advocacy is being done so that the data yari uburyo bashyira hamwe bakagira uburyo bafashwa bari hamwe. So hariho tubonye problems in DNA repair systems turebye ebyiri gusa, this hereditary non-polyposis colon cancer hakaba na xeroderma pigmentosa. Ariko si uvuga ko arizo zonyine zihari, haba hariho n'izindi, hari n'izindi zizavumburwa namwe mushobora kuzavumbura. So kuko nubwo genome y'umuntu yavumbuwe okay mbere baba ngo hari gene yitwa gutya, gene yitwa gutya ku mwaka wa 2010 nibwo na 11 nibwo abantu bashoboye kumenya neza details za genome y'umuntu, amagene yose arimo uko ameze. Ariko nubwo bimeze gutya ni structure is function zazo hari ziba zitaramenyekana n'ubu zikivumburwa za 2013 and so on. So bigikomeza. So yes,
sorry lecture on the previous slide I
can you talk? Hello? So it seems we are gone. So let's continue. So the limitless replicative potential iterwa n'iki? So it is known that the cells, the normal cells, they have a limit number of cell division they can get. Why? Nuko iyo cell, when the cells makes a cell division, of course you understand the DNA also will replicate. Here we have copy zisa kuri buri cell. But there are parts of the genome which are not replicated as such. These are called telomeres. Telomeres ziba ziri kuri ku mpera za chromosomes. So when because they don't replicate themselves, uko seriri byari yindi zigenda ziba short. Uko ziba short, iyo zibaye short cyane umubiri ntabwo wemerera iyo cell kongera gukora cell division. Nako umubiri uteye. So niyo mpamvu ko buri serire ishobora kwemererwa gukora division 60 cyangwa 70 hagati aho ngaho. Izi zishobora gukora replication of course. Ntabwo irenga aho ngaho. So ikibazo cyo ni iki? In the cells that have disabled checkpoints, that checkpoint babonye retinoblastoma gene and the p53 gene, DNA repair pathways are inappropriately activated by shortened telomeres. So no kuvuga iki shortened telomeres ubundi retinoblastoma gene cyangwa p53 y'ibibonye ihagarika cell ntiyemerewe kwa cell division. Ariko iyo izi checkpoints zawe imitated, ya cell ifite telomere yabaye very short yemererwa gukora cell division. Kandi iyo byemereye hazamo amakosa buri gihe iyo telomere yabaye ngufi muri DNA isanzwe itari telomere nabwo hazamo mistakes or mutations. Ikindi kibikurura ni iki nuko iyo cellule igira ubushobozi bwo kongera telomere yayo ikayigira ndende. dukoresheje enzyme bita telomerase muzajya mubibona literature. So the telomerase will make the telomere to be longer than it was. Ibyo bikaba nko gutrika serire nko kuyereka ko itarasaza. It is still young, it can divide. Ariko nubwo igiye gukora division, it has problems. It has mutations and many mutations here. So ibyo rero bituma habyo massive chromosomal instability and massive cell death and so on, ibyo bita mitotic catastrophe. So the tumor cells reactivate telomerase first, staving off mitotic catastrophe and achieving immortality. So normally hejuru zirapfa iyo telomerase itakoze telomere ngo iyongere igere ndende. Zirapfa, which is mitotic catastrophe, because most of them they die. But when the telomerase is activated, thus the cell will not undergo death. It will just continue to divide. Niyo mpamvu abafana yagize immortality. Immortality ivuga ko imbwa idapfa, ahubwo ni uko ihora isimburwa n'iyindi ku buryo zita disappear. So sustained a development of sustained angiogenesis. So as we said, the tumors cannot enlarge beyond 1 or 2 millimeters in diameter of thickness unless they are vascularized. Kandi icyo ituma mugomba kumva neza nuko muri histology mwize ko ntabwo epithelial cells ubundi zihura na blood vessels. Blood vessels zirangirira muri za laminar propria connective tissue, ntabwo zinjira muri epithelium usanga yagiye muri epidermis. Ariko niba hari cancer yavuye muri epidermis cyangwa indi epithelium, kugira ngo zikomeze kubana uko zibona amaraso, icyo gihe bituma hari amaserire, hari blood vessels, new blood vessels zikorwa zikaninjira muri epithelium, kandi ibyo n'ubundi biba muri normal conditions. So beyond this size, the tumor fails to enlarge without vascularization because hypoxia induces apoptosis by activating the p53. Niko bigenda. Ariko niko byagomye kugenda, ariko reality si uko bigenda, ahubwo hari hypoxia induced factor ikorwa cyangwa iba activated igatuma habaho new blood vessel formation. Mu gitondo nabivuze. So revascularization is important in tumor growth because it will supply nutrients and the oxygen. Ndetse abarwayi ba kanseri barananuka cyane nubwo bashobora kuba n'igihe bashobora kurya. Kubera iki energy yose ibyo bakonsoma byose amaseri ya kanseri akora ku buryo bavuga abidevia bikabibyara. So the newly formed endothelial cells stimulate the growth of adjacent tumor cells by secreting growth factors, insulin-like growth factors, platelet-derived growth factor, etc. So without access to the vascular, the tumor cells cannot metastasize, of course. Niyo mpamvu serire zikora uko zishoboye kose zikabona ibyo zikeneye ngo zikure kandi zikore metastasize. I mean here cancer cells. So iyo urebye imikorere ya cancer cells, wayangura ikintu kiba kiri programmed neza kubona zikorana ubwenge bwinshi ntaho ziri programmed. So tumor angiogenesis is controlled by balance between angiogenic and anti-angiogenic factors. So we have angiogenic factors, which are vascular endothelial growth factor and the basic fibroblastic growth factor, beta fibroblastic growth factor. So noneho iri anti-angiogenetic, we have a few genes which fights against the angiogenesis. Here we have an example of thrombospondin 1. It is an anti-angiogenic factor produced by tumor cells themselves. Urumva nubwo zikora ibizifasha, rimwe na rimwe zikora n'ibizangiza ubwazo. So in their growth, most human tumors do not induce angiogenesis. They exist in situ without developing blood supply for months, even for years. Ariko nyuma hazaho ibibazo, as say, this is the accumulation of mutation. Then some cells within the tumor, the small tumor, switch to angiogenic phenotype. Birumvikana ushobora kugira ngo kuba izi serire zitagera kuri blood supply, ukumva ko ari ikintu kiza ku mubiri, cyangwa izo serire ko ziba zibangamiye. Ntabwo ziba zibangamiye, ahubwo reka tubyite ko ari amayeri yazo. Aba ari amayeri kugira ngo zikore ibintu byazo nta muntu uzikontorora. kubera ko ikintu kitagera kuri blood vessels ntabwo umubiri ugikontorora very easy. So nuko ziba ziri aho ngaho za lymphocytes zirwanya kanseri zishobora kuba yakoze inyuma muri blood vessels na lymphatics, so ziberaho zigakora nk'igihugu cyazo mu kindi zigakora ibyo zishaka. They acquire new mutations, accumulation of many mutations. No, muri iyo nzira kujya many mutations nibwo rimwe na rimwe havamo phenotype cyangwa se clone, subclone iri angiogenic ituma noneho okay noneho dukeneye blood vessels ariyo ishobora no gutera invasion ikagira metastasis nkuko twabonye muri diagram. The molecular basis of angiogenic switch involves increased production of angiogenic factors and the loss of angiogenic inhibitors. So this we can understand. Kugira ngo no blood vessels zihariye nuko factors zishaka blood vessels ziba zabaye nyinshi cyangwa zanesheje anti-angiogenic factors. So the hypoxia induced factor 1 niyo navuze kare iyo hajemo hypoxia then niyo ituma habaho. This is sensitive to oxygen and it is a transportation factor. Iyo haje hypoxia then it will activate the formation of new blood vessels through these pathways. Azami von Hippel-Lindau protein and so on. And so the inheritance of germline mutation in von Hippel-Lindau protein or gene causes the syndrome having the same name. Bigaragara cyane cyane muri hemangioma. Hemangioma means a benign tumor arising from blood vessels. So hemangioma of the central nervous system, renal cell carcinoma of course it is a carcinoma, a cancer arising from tubules, renal tubules and the renal cyst. So other factors regulate angiogenesis, for example, 53 induces synthesis of thrombospondin 1. Twabonye ko ari anti-angiogenic. Ibyo bisobanura ko na P53 is indirectly anti-angiogenic. So the mutation in P53 will cause the downregulation of the thrombospondin, therefore increased angiogenesis. Bigaragara ko P53 ifite akazi gakomeye cyane mu kurwanya kanseri mu mpande nyinshi zishoboka, ifitemo role ikomeye. So ability to invade the metastasize. Invasion and metastasis are biological hallmarks of malignant tumors. Nicyo cyambere kizira. If hari igihe disk ngo this is not benign, this is not a cancer, cyane cyane cancer zigaragaza amaserire ntagaragare pasa nabi nk'iza thyroid. Hari igihe tujya no this is a benign, no this is a cancer. Ariko hajeho evidence ko hari metastase yajangwa invasion, then ntawongera kugira icyo avuga. Everybody will agree that it is a cancer. The major cause of cancer morbidity and mortality nta kindi ni ukwera yagize invasion, it destroys surrounding tissue or it metastasizes. Otherwise cancer igumye ahantu hamwe ntacyo yatwara umuntu yaguma akabaho nk'uko abana na benign tumor, ariko ntabwo ijya ibigenza buri gihe it infiltrates and metastasizes. So for tumors cell to break, so kugira ngo habaho break loose from primary mass, nuko hari agace kiyomora kuri cancer kuri tumor inini, uduce twase nk'uko twabonye kuri diagram, tukavaho tukinjira muri blood vessel lymphatics and it produce a secondary tumor at a distance site. So certain series of steps have to be followed, aribyo twasobanuye kare kuri iyi diagram yango ntabwo bigaruka. So ngira ngo ariko hari ikindi tutavuze ahangaha, so ntabwo dushaka kuvuga ibintu byose, but reka mbivuge mu magambo. Cancer navuze kare ko cancer uburyo ikora metastasizing, ishobora kunyura muri lymphatics, ishobora kunyura muri blood vessels, ishobora kunyura around nerves, ishobora kunyura muri space aho ngaho cyangwa se kuba organe yegera. Nukuba kanseri ya let's say ya colon ishobora gufata transverse colon, ishobora gufata igifu vuba kubera ko hari aho bisa n'ibifatanye. Okay, bigenda bihura nuko bidafatanye pase, it don't touch each other, ariko biba byegeranye bihuye birahura. So aho ngaho rero babyita metastasis by contiguity. Contiguity kwa ko organs zegeranye. cyangwa se cancer of the bladder ikinjira muri cervix cyangwa muri uterus. Kubera ko just ziraturanye. This is the metastasis by contiguity. Hakaba na metastasis by continuity, ni yindi inyura muri empty space, ikanyura muri peritoneal cavity, ikava muri ovary ikagera ku gifu, Krukenberg tumor. So the other two methods are pathways are lymphatic and blood vessels. So if you are asked what are the pathways of tumor of cancer metastasis, so if you mention there are 4: by bloodstream, by lymphatics, by continuity through that there's a created spaces, or by contiguity. So perineural invasion nayo ibarwa muri continuity, kako bisa no hari space biri hagati ya nerve and the surrounding tissues, ya space karibu amaziriya tumor cells zinjira. So these are the main pathways of tumor metastasis. So ibyo karikwa icyo nashaka kuvuga kanya ni kirere. Ntabwo kanseri rero ko yango inyure mu maraso cyangwa mu mwijima, ntabwo cyangwa muri lymphatics, ntabwo ari ibintu bipfa kubaho gusa. Ikizwi nuko carcinomas they metastasize using lymphatics. I hope you understand this. Carcinomas metastasize usually using lymphatics. Sarcomas they metastasize usually using blood vessels. So this has implication nusanga umuntu afite tumor cyarabaye kinini ukabona ko ari cancer, ariko wareba lymph nodes ugasanga nta nimwe ifite ikibazo, ni ukuvuga ko most likely this is not a carcinoma. Kuko yiba carcinoma byakunze banyuza muri lymphatics ukayibona muri lymph node. Bigeze muri lymph node ntabwo ipfa kunyuramo gusa, lymph node bibanze karwana bikabyimba ugasanga kuzuyemo tumor cells, then wakora palpation ukayibona cyangwa CT scan ikabona. So iyo usanze lymph nodes zidafite metastasis kandi hari a large cancer, even before histology, iyo ngiyo ushobora kuvuga confidently this is most likely a sarcoma, kuko yiba carcinoma yari kunyura muri lymph nodes. Of course there are exceptions, and hari niyo mperutse kubona kuri stashika umwana yafite byimba muri lymph nodes zo kuri neck. Then I did cytology, I found a cancer cell. So I found they were looking like a sarcoma. Ariko nkegera ikibazo muri literature birazwi ko sarcoma ntabwo zipfa kunyura muri lymph node. So I was reluctant to say this is a sarcoma. Ariko ndabivuga ndabona isa na sarcoma, although ukurikije theories ntabwo yagombye kuba ari. So they did the biopsy, that it was confirmed to be a sarcoma. So it is an exception. Is in the exceptions are in cancers of the thyroid, those any carcinomas, ariko hayitwa follicular carcinoma yo yinyurira muri blood vessels. Now it's papillary carcinoma ikanyura muri lymphatics. So in any bizwi, it is an observation. So nobody can explain why, but it is an observation. It is known like that. So icyo implication icyo bibafasha nka clinicians navugaga before we become specialists, nuko it is that when you see a patient with a cancer, with a tumor, with features of a cancer, but without a regional lymph node involvement, you can think first of sarcoma instead of carcinoma. And when you see a tumor in the breast, let's say, and the lymph nodes in enlargement in the axilla, you can confidently say this is a carcinoma, because the carcinoma passes through lymphatics and therefore lymph nodes. So I don't have a very slide, but you must understand it. So in summary, there are hundreds of cancer-associated genes. Some such as 53 are commonly mutated. Others such as ABL, in the Kawanya, in the leukemia, Philadelphia chromosomes. So some are specific to some cancers, others are just commonly mutated in any tumor, such as P53. So it is best, therefore, to consider cancer-related genes in the context of 7 fundamental changes in cell physiology that together dictate the malignant phenotypes. self-sufficient in the growth of signals. These are protoncol genes. Insensitivity to tumor suppressor genes or growth inhibitory signals. Evasion of apoptosis. No kuvuga, they escape the work of p53 gene. Limitless replicative potential. We have seen this limitless replicative potential because the genes such as the retinoblastoma gene and p53, which control the cell cycle, will no longer be active. Genomic instability because of defects in the DNA repair mechanisms. We have seen two examples of dermal pigmentosome and the hereditary non-polyposis cori syndrome. Development and the of sustained angiogenesis and ability to invade and metastasize. So even if they are cancers in general, at molecular and the clinical levels. So that's all for this presentation. So if you have a question, then you can have a discussion. And after that, we must talk about the continuous assessment test. Okay, thank you. So the floor is yours.
Thank you, lecture. Nagize ikibazo kare mitangira ikibazo cya connection. Aho nari kuri genomic instability. Twari twabonye yuko yinvolvinga kuri DNA repair system. Ariko hari iyo ntarindi kumva neza aho ikora neza yitwa xeroderma pigmentosome, ya yindi y'abantu bafite ibibazo by'uruhu batabasha kujya kuri UV light. Ntabwo nari ndi kumva neza kuri stage ya DNA replication aho mutation iba yabaye.
Mutation nabivuze neza no mu Kinyarwanda nuko DNA uzi uko ibiteye ni nucleotides zikurikirana. Habaho rero hakaza timine, akenshi ni timine iza ikitera muri one strand ariko ntinagire indi nucleotide iriye nayo ku yindi strand. So on one nuko ko kuri strand imwe ufite nucleotides nyinshi ujyanye n'indi strands kubera za timine ziyongere. Izo timine ntabwo ziba ziri linked to another nucleotide on the other side. Uziko timine igomba kujyana na adenine. So icyo gihe rero iyo ni ikosa ribaho kandi akenshi bikabiterwa na ultraviolet light. Umubiri rero ufite mechanism yo gukora wita nucleotide excision repair pathway yo kuvanaho utwo twa thymine tuba twiyongera batwita pyrimidine dimers. Niyo term iri general bakunda gukoresha. General term. So pyrimidine dimers ziba zaje zikitera ahantu zidafite their coupled nucleotide on the other strand, DNA strand. So we have a nucleotide repair mechanism, nucleotide excision repair mechanism. Noneho rero hariho abantu bamwe badafite iyo nucleotide repair mechanism. Abo nibo twita bafite syndrome yitwa xeroderma pigmentosome syndrome. Sinzi niba byumvikana. So abo rero ntabwo kubera ko ntibashobora kurepairinga izo mutations, because these are mutations, are changes. They cannot repair them, therefore they will develop cancers very easily, skin cancers very easily. So risk bazihuje n'aba albinos. So aba albinos bo kubera ko iyo DNA repair mechanism tifashwamo cyane na melanin. Albinos bazize ko ntabwo afite melanin. Kwatagira melanin rero ultraviolet lights ziramwangiza uko zibonye. So ni ibintu tubona kuri histology utagera no muri molecular aspects. Usanga muri dermis collagen bundles fibers zarabaye blue, zarabaye zimeze nka they are oscillating, zimeze nka waves kandi zaracikaguritse, fragmented. Iyo tubonye tugira this person has a solar injury, afite injury iterwa n'izuba, so therefore abagomba kwirinda. So kuri albinos ni ibintu byose kwibona. N'aba rero bagize derma pigmentosome kuri histology urabibona ko uruhu rwananiwe kwihanganira izuba ahura naryo. Niba rero adafite repair mechanism uretse izo fragmentation of the collagen nuko azajyana za mutation, therefore develop skin cancer. So ntabwo rero xeroderma pigmentosa umurwayi ari mutation cyangwa iki, ahubwo iyo uvuze syndrome, it is like a set of signs and symptoms abantu runaka bahuriraho kandi bafite ibintu bahuriyeho. So byasanzwe ko abantu bafite icyo kibazo, nanabivuze clinically ni umwana uzaza usanga ahora areba hasi ntashobora kureba hejuru, cyane cyane iyo hari urumuri, uretse n'urwiza n'urundi ararutinya kubera donc ni ariyadabuta. Kwiyadabuta kwe ntabwo ni ugutinya icyitwa urumuri cyose. Ikindi kubera ko hari igihe abana bitoroha kubagenzura, abo n'andi bakenera nabo bakabajyamo, still agira skin sun damage, ugasanga uruhu rwarakurutse nk'urw'abasaza, rwarakuze nk'urw'abasaza cyangwa abakecuru. So iyo yose ubitanyije ushobora kuba uyu murwayi afite xeroderma pigmentosum syndrome, which will be confirmed by molecular tests, of course. Okay, further questions? Okay, no further questions? So I think I discussed with the president. For P53, why does it required in DNA repair? Cyangwa ariko hari ibibazo tugomba kubaza why, nko kubaza ngo kubera iki gihugu kiyoborwa n'umuperezida cyangwa kuki kigira abapolisi, nyine bahari kugira ngo bakore umurimo bashinzwe, none yashizweho kugira ngo igenzure, keretse niba uvuga ngo nta kazi ikora ubona nta kimaze. So niba ifite akazi ikora rero, yashyizweho, uwayiremye yayishyizeho azi icyo ikora, kandi natwe mu bwenge twashoboye kumenya nuko tubona akazi ikora. Why is it required for DNA repair? Ngo kuki umupolisi atekana kandi nashinzwe umutekano. What happened to the DNA initially? Maybe sinzi icyo ashaka kubaza ahangaha. DNA when iri gukora cell, iyo hari kwa cell division cyangwa se DNA replication, ni ibisanzwe ko ashobora kubikosa. Ikosa no kuvuga iki, ni igihe DNA iri kwikopayinga, mwarabyize muri molecular biology, no kuvuga haza kopi imwe igasoma ikabate okay hano hari timine, ubwo iraza kuri strand yindi ya kabiri haritazaho adenine and so on. Bishobora kuba bikosa aho kuza ngo haze adenine akazaho cytosine. Iryo ni ikosa ribaye. Niba ushaka kuvuga ngo ni iki kiba cyabaye kugira ngo P53 ize kwintervene. So nibyo bishobora kwizana spontaneously, twabibonye, can just appear spontaneously. Kubera ko ibyo ni ibintu bikorwa buryo bwihuse, so byoroshye gukwazamo error. Nubwo amakosa azamo make cyane ariko ashobora kubona, ariko amakosa akanabamo bitewe n'izindi mpamvu y'uko umuntu akura and so on, nabyo risk zo kugira accumulated mistakes or mutation increases. So usibye izo spontaneous mutations, none hari ziterwa na environment, hari izuba, hari irradiation, hari imiti wafashe, hari oxidants nyinshi wariye cyangwa se zakoze kubera ibyo wariye, izo zose zikagera damage kuri DNA. Ibyo bintu byose rero P53 igomba kubidetecta mbere yuko cell yemerwa kujya muri cell division. So njyango nari washaka kubaza ni iki ubundi ibyo bya ayo makosa yabaye atega ngo DNA kugira ngo P53 irinde kuza gukora intervention. So nuko ushaka kubisobanura.
Yes, thank you, lecturer. Another question is about the how EGFR group of growth factor receptors work, because we already know about G protein coupled receptor, ligand receptors, and enzyme receptors, but I don't know anything about EGFR family, how it work? EGFR.
EGR. Oh, epidemic growth factor. Okay, epidemic
Yes.
growth factor, you understand it is which vision of a cell or is the squamous epithelial cells of the skin. So ni yavumburiwe none iyo factor bikamenyekana ko inyura muri receptor yitwa epidermal growth factor receptor. So ni family rero izamo ibintu byinshi kuvuga ko ubu tuzi wenda akazi kose ikora nta jine nimwe ushobora kuvuga ngo izwi akazi kose ikora kuko uko bukeye ko bwize bagenda bavuga ati twasanze iyi jine burya inakora ibi n'ibi. So uretse rero kuba icyambere cyari kizwi nicyo cyo gutuma epithelial cells they can divide and form the new cell. So initially that is ariko byagaragaye ko iyo igize mutation ishobora gutera cancers in different other organs, not only epidermis. Ko kabonye muri breast, when of ngo breast muri embryology it comes from the skin, maybe that's the reason. Ariko tunayibona mu zindi cancers nka pancreas and so on. Ngira ngo hazamo ibintu byinshi gene zagiye zivumburirwa ko zishinzwe iki n'iki ariko nyuma zikanahabwa izina rijyanye n'ibyo nk'uko nabivuze wenda kuri zinaba mutated mu zindi ndwara and so on. So akazi ka epidermal growth factor receptor na factor ubwayo na receptor ubwayo nako ngako initially karako gutuma epidermal cells ziyongera cyangwa zisimburwa. So ngira ngo mu kubikoramo research niho usanga yo n'urugero ubigizeho ushaka kubyiga. Hari studies zikorwa ku nyamaswa and so on, so kayena muri laboratoire ukabwira ngewe nshaka mu nkorera imbeba idafite epidermal growth factor receptor cyangwa ziyifite limited mu buryo ushaka, bakabikora gutyo ukayishyira hariya ukayigaburira bisanzwe cyangwa se zimwe ukazigaburira ibintu bimwe izindi bindi ukazara wenda nize za develop iyi cancer. So nibyo bikorwa mu marabo, ibyo rero bigatuma nabyo nibyo bituma bimenyekana ngo burya ya gene ubikora. Ariko akenshi bitangira ari curiosity gusa umuntu ayize, ariko kamwe kugira ngo baguha fans zo kubikora nuko babona ko ari ibintu biri coherent. Ntabwo wavuga ngo I'm thinking that retinoblastoma gene when it is mutated when itera ko umuntu agira inzara z'umukara, ntabwo amafaranga ibyo ntacyo bivuze. So hagomba kuba hari ibintu bigaragaza ko hari inyamaswa and so on. So otherwise nuko curiosity ziza nko kubibaza, you may explore and see other possible functions of these genes. So I said what I know so far and what is written so far. So hari function isanzwe ifite muri normal tissues, noneho hari naho byagaragaye ko iyo ifite ikibazo hari cancers runaka zivuka. That's all I can say.
Thank you.
You're welcome. So if there is no other question, then when would you like it before the final exams?